All right, folks, let's get started. So good morning and welcome to our 29th annual Respiratory Health Symposium. My name is Melanie Langille. I'm the president and CEO of the New Brunswick Lung Association. And this morning, I want to draw attention to the point that New Brunswick Lung Association offers bilingual services, and we are very pleased this morning to provide simultaneous interpretation. At the bottom of your screen, you can select your language of choice from the globe-shaped icon at the bottom of the Zoom screen. So, bienvenue au 29e Symposium annuel sur la santé respiratoire.
Welcome to the 29th Annual Respiratory Health Symposium. I'm Melanie, I'm President and CEO for the New Brunswick Lung Association. And at New Brunswick, we use bilingual services, so we're really happy to offer you simultaneous interpretation today. All you have to do is choose the language of your choice on the bottom of your screen, and the icon interpretation in French or English.
Of our sponsors. So let me take a minute to thank our gold sponsor, which is Boehringer Ingelheim Canada Limited, our silver sponsor, Merck Canada, our bronze and community partners, Pfizer Canada, Sanofi Pasteur, and Vital Air, for their support in providing this continuing education session for respiratory health professionals and students. And I'd also like to thank you for taking the time to join us this morning. I'd like to take a moment now to recognize that the land on which the New Brunswick Lung Association operates is the traditional and unceded territories of the Mi'kmaq, Wolastoqey, and Passamaquoddy communities. We are committed to working towards the goals of the Truth and Reconciliation Commission of Canada, and we continue to partner with Indigenous communities across our province with a shared goal of cleaner air and healthier lungs for all. And I'd like to note that in observance of the National Day for Truth and Reconciliation, our organization will be closed tomorrow, September 30th. We have a great lineup of speakers this morning on a variety of lung health topics. We're pleased to offer certificates of attendance and professional development hours through various professional associations. So if you require a certificate, we do ask that you reach out and request this. Dusty, could you just pop Barb's email into the chat there now? So just email Barbara Walls. She is the leader of this symposium. She will connect you with the appropriate certificate for your association, or for those students that are attending here, we also confirm attendance with your instructors. And now I'll pass the virtual baton over to Barb to introduce our speakers, or our first speaker.
See if I have that. Yes, good morning everyone and welcome. I'm excited as usual. This is our 29th annual symposium and my 12th, and it never gets boring, that's for sure. So as Melanie said, we have quite a roster of speakers. I'll just finish introducing myself. I'm the Director of Health Programs with the New Brunswick Lung Association. So we will be moving along quite briskly. The symposium is recorded. We have what I call a very fluid break times, just because some of our pre-recorded presentations may run a little over. So please feel free to step away from your laptop or computer or cell phone if you need a break and it's not actually happening as the time is slotted there on the agenda. So as it happens, I'm going to be reintroducing Melanie Langille, who is our first speaker. She's in Toronto, so it's pretty early for her right now. And Melanie's going to be speaking on climate or environmental. Oh, sorry. Her topic. So Melanie is an environmental scientist with a background in human health risk assessment and contaminated site assessment with a specialization in vapor intrusion assessment. Melanie began her tenure with the New Brunswick Lung Association as the Director of Program Development, Environmental Health, and brought to life a long-term vision for the organization of the Foundation for Resilient Health. She brings to the organization a strong science background with a bachelor's degree in biology and a master's degree in environmental science, and a passion for knowledge sharing. Her previous experience in environmental and human health risk assessment, environmental impact assessment, and contaminated sites management gives her a unique perspective on the importance of the environmental and social determinants of health. Thank you, Melanie.
Thanks, Barb. Before I can share my screen, I think, Dusty, you need to stop sharing. Perfect. Bear with me. All right. Barb, can you let me know, do you see my presentation?
Yes, I do.
Okay, and it's in slideshow mode here now. Okay. Oh, shoot, I do need some notes. Anyways, that's okay. Thank you, Barb, for that introduction. And I am going to be speaking about climate change, some specifics about the fine particulate matter and the implications on climate change on those air pollutants, and obviously how that relates to lung health. So we'll get started here. So again, like I mentioned this morning, that the land that the New Brunswick Lung Association operates on is traditional and unceded territories of the Mi'kmaq, the Wolastoqey, and the Passamaquoddy nations. And we are pleased to share this land, and we are working closely together to go forward hand in hand and steward the land that really supports our health. I'm joining you this morning from Toronto, and I had grabbed the information on land acknowledgement for here, but I am dismayed to see that I cannot see it right now. So I will not try to do this from memory, but just to recognize that there are a number of First Nations communities that were traditionally on this land here in Toronto, and it's now home to a number, remains home to a number of communities. And the City of Toronto, I'm really excited to share, is that seems to be very progressive in its work towards truth and reconciliation. So I was really comforted to see that as I was here. At the New Brunswick Lung Association, our vision is all people free of lung disease. So I'd just like to throw this slide up here to frame any sort of thing that I'm talking about, because everything that we do, myself, as Barb said, I'm an environmental scientist, a lot of what I drill down into the weeds on is environmental effects on health, but everything is done with the inspiration of working towards this vision of all people free of lung disease. And this statistic here, probably those around the virtual table today are quite familiar with, but 1 in 5 New Brunswickers lives with lung disease. And that really gives me pause. That's one person in every household, family, circle of friends. So it really is a concern across our community. Now, the World Health Organization has deemed air pollution as the biggest environmental risk to human health. So it's an area that we at NBLA have put a lot of effort into over 10 plus years to addressing air pollution as a threat to human health. But what is the air like in Canada? What's the state of the air in Canada? It is, we can get complacent and think that, compared to places like China and India, our air quality is pretty good. That's a pretty low bar to compare ourselves to. So in reality, when we look at, the standards that are in place right now, according to a report published by Health Canada and Environment Canada in 2020, and I do have all my references on the very final slide here. Happy to share anything, any direct questions that are here and the sources cited, absolutely. But about 1/3 of Canadians live in areas of poor air quality. So that's 1 in 3. That's pretty startling. And that poor air quality has been attributed to over 15,000 premature deaths every year. And when you think about our healthcare system and the crisis that we find ourselves in, that translates into over $100 billion in healthcare costs, in lost productivity as people are not able to work at their regular job and contribute to society to their full potential. So it's pretty startling. Let's drill down a little bit into particulate air pollution, which is an area that we focus a lot on here. Where does it come from? If you're unfamiliar with particulate air pollution, it is released during forest fires, wood burning, really in any source, whether it's forest fires or furnaces, wood stoves, campfires. Pollen is a particulate air pollution. Construction can lead to a lot of dust and debris, and that gets into the air and is pollution. agriculture as well. Think of large fields being plowed and the dust that can come off of those. And certainly fossil fuel combustion. So that can come in the form of traffic, local traffic, heating. And then we're also, we're not just subject to the pollution of our local area, it's also can be transported from long distances away. And so you may recall last year, I can't remember if it was July or August, but in the summer, New Brunswick had some wildfire smoke that was transported all the way from fires in Western Canada, so Manitoba and further west. So although we don't experience a lot of localized forest fires, knock wood, we're quite lucky in that regard. We are not immune to the forest fires, smoke pollution. I want to draw attention to this fantastic website. So if you work in the area of respiratory health and you want to dabble and learn a little bit about air pollution, the effects on health, the CCME, the Canadian Council of Ministers of the Environment, on which we have a representative from our local Department of Environment, they put together this fantastic website. It's very interactive. I've grabbed just a snapshot right here, but you can drill down into these 5 criteria air pollutants and learn about where they come from, what are we looking at in terms of sources of these pollutants, how are we doing compared to the Canadian Ambient Air Quality Standards, what I'll refer to as CAQS. What are we doing, where are our emissions compared to that, and you can tailor some graphs and things. If you're a data geek like myself, you can look at some graphs and toggle on and off different provinces or on and off different pollutants, and it can really give you a good snapshot of where the quality of our air is, where it's been, and where it's going. So big shout out to CCME. This website is fantastic. When we talk about the CAQS, the Canadian Ambient Air Quality Standards, these are standards that have been progressively ratcheted down over the years with the intention of cleaning up the pollution, particularly related to industrial emissions, with a goal of cleaning up the air over time. It's not practical to dramatically change the standards of air pollutants when it comes to not wanting to really affect the businesses on a large scale. If all of a sudden tomorrow we say you cannot pollute the air, period, then all of those industries that we rely on would cease to be able to operate. So it's a progressive ratcheting down, and the Lung Association has served as part of these technical committees under CCME that have been working towards ratcheting down these CAQS. So on the PM 2.5, the particulate matter that's less than 2.5 microns in diameter, that's where we focus a lot of our attention. That standard is currently under review with CCME, and I sit on that committee. But to show where the standards are going, the World Health Organization just recently has indicated that annual average concentrations of PM 2.5 shouldn't exceed 5 micrograms per cubic meter. To put that in context, a couple of slides ago, but our current CAQS is 8.8 or 8.5, in the 8 range. Nova Scotia is being quite progressive. They have developed proposed air quality standards for their province. Just in recent months, it was out for public review, and they propose to match the World Health Organization. So shout out to Nova Scotia for being very progressive there. And at the national stage, those CAQS are currently under review, and certainly the World Health Organization recommendation of this 5 micrograms per cubic meter is certainly a topic of discussion. But to put it very bluntly, there is no safe level of exposure to PM 2.5. So it's what we call a non-threshold hazard. There are some hazards, there are some hazardous substances to which we can be exposed to low levels and not really suffer any negative effects, but it's only at higher, a particular high concentration. There's literally a tipping point between no observed effects levels, and then effects levels beyond that in terms of concentration. For PM 2.5, that's just simply not the case. So for those that are living with lung disease, particulate pollution, we think about those days where we had the wildfire smoke transported in from the west. We see increased hospitalizations for those living with lung disease, increased number of asthma symptom days. On the cardio side of things, cardiac ER visits. So cardiovascular and lung health, when it comes to particulates, it's all kind of one and the same. We see a lot of acute bronchitis episodes, acute respiratory symptom days, and simply, you know, something that that may or may not get picked up in the surveys and the research that's being done is restricted activity days. So those that are living with lung disease may find it particularly difficult to get around and do their day-to-day activities when the air quality is poor. And when we think about the extra consideration that we need to have for children, the effects of air pollution on developing lungs are even more stark. So children, smaller body, so for any unit of pollution on a weight per weight basis, children really bear the brunt of that exposure when you compare it to the body size of an adult. They're also in this period of rapid development. So systems are developing, organs are developing. Any exposure to pollution is just a recipe for an increased risk of things to go wrong. There's also been a lot of studies to associate air pollution exposure in the mother to lower birth rate, premature birth, and there's a host of issues that go along, you know, lifetime health issues that come along with either low birth weight or premature birth. So again, the infant, or the fetus rather, can be exposed to the air pollution actually in utero. The particulate matter, fine particulate matter, crosses the placenta, crosses the blood-brain barrier. So all of our natural defenses to keep pollution out, this stuff can kind of get around it. So that can affect organ development, it can affect lung function, and we also see a marked increase in asthma incidence in children that are exposed to air pollution. So that's pretty stark. And then when we look at climate change, the Lancet, the medical journal, this quote has been quoted I don't know how many times, but we say that climate change is the greatest threat to global health of the 21st century. And they've been saying this even before the pandemic came to bear its brunt on us, but I would say that this continues to be relevant, and that the effects of climate change on health really bring into contrast the effects of the pandemic on our health. It just was very fast and very acute that we saw it. But climate change, in my opinion, and there's literature to support this, is really going to blow COVID out of the water. So the effects of climate change on air quality, so this higher heat is kind of what we start to think about when we think about climate change, think with the previous terminology of global warming. Warming, cooling could be different depending on where you are. In our area of the world, yes, we are in a warming situation. We are in a higher humidity situation. So we are having longer and more intense heat waves, longer and more intense periods of high humidity with no break at night. And our colleagues at Health Canada are very well versed in the effects on this heat specific effect on the body. When we're thinking about strictly air quality, that heat and humidity traps the air pollutants closer to the earth. So in the absence of extreme heat and humidity, some of that pollution that we produce in our day-to-day activities will be dispersed further up into the atmosphere, where I won't say it's not a problem, but it's not as much of a direct problem on respiratory health. But with this higher heat and humidity trapping the pollutants more at breathing height, you know, the 6 feet and lower, closer to the earth, individuals are exposed to higher and higher levels of pollution. They also are experiencing longer pollen seasons. So when you think about Spring is coming earlier, winter is coming later. That translates into a longer growing season for plants, a longer pollen season. Got another slide on this, and also the increase in forest fires. And so we can see that in the news over the last couple of years, the horrendous forest fires that happened in BC last year. A number of people lost their lives there. And it is something that we are going to continue to see as we are living in this changed climate. So when we think about pollen and allergies, I like to throw it out there that I am allergic to pretty much everything that's alive. So I personally am experiencing this to the extreme. So a longer, more intense allergy season. The plants are growing longer. I have a hypothesis and couldn't find any literature to support it, but from an ecological background, the range, geographical ranges of different plant species changes over time with the global climate. So there is opportunity for those ranges to expand into the north. So we may even be, whether we are right now or it could be in the next couple of generations, exposed to pollen of species that we even haven't before. So if you are a person with allergies and you travel, you may notice that, generally in February I'm fine, but when I go to Florida, I'm all stuffed up in February because there's just different pollen, and perhaps you haven't experienced that before. But there is literature to support that climate-driven pollen trends are on the rise. So there is more pollen out in the air. This photo is absolutely terrifying to me as a pollen allergy sufferer. But there's also some literature to support that the aeroallergens, the allergens that are in the air, when you add that with heat, and that actually increases the sensitization of the individual, or in other words, increases the allergenicity of that. So we are becoming, our reactions to pollen exposure are becoming more extreme. On the forest fire side of things, we are noticing more intense, more frequent forest fires across the world, across Canada. In Canada, an average of a little over 2 million hectares of forest are burned every year. And to put that into perspective, I don't usually visualize things in terms of hectares, but that's about a third of the province of New Brunswick that the forest is completely decimated every year in Canada. And it doesn't just affect those living local to the area of fire. And let's not forget those folks. Extreme heat, extreme air pollution, loss of life has happened there. But because we're speaking more in the context of New Brunswick today, we need to be mindful that there's significant potential for long-range transport of this smoke pollution from areas west of us coming towards our province. Drilling down into, we talked about particulate matter, and then we talked about PM 2.5, so that's particulate matter that's extra small, under 2.5 microns. Part of what makes up particulate matter, and particulate matter is very complex. It's bits of stuff. It's bits of gases, liquids, solids. One of those components is black carbon. So black carbon is emitted during the incomplete combustion of things like fossil fuels, things like biomass, so residential wood burning, forest fires. These are all things, I think in layman's terms, we could use the term soot. But the implication of that black carbon as part of the air pollution is that it is little flecks of black stuff. And so it actually absorbs solar energy and contributes to climate change. So it's what's known as a climate forcing pollutant. So the more black stuff out in the atmosphere, the more the sun's energy is trapped again close to the earth, the more we warm even faster. And so that black carbon, again, is a component of of the PM that we talked about, it does have cardiovascular and respiratory effects. That graph, I've always been told putting PowerPoint presentations together, never put a graph, you lose your audience. And inevitably, I've got 2 or 3 of them in here, so sorry for that. But I found it's really interesting. This comes from Environment Canada. It's air pollutant emissions report. And just where is that black carbon coming from? Big chunk here, the dark blue, is transportation, which is, I'm here in Toronto right now at an electric mobility conference. It's an area that the Lung Association focuses a lot on because it does contribute so much to the black carbon and the PM 2.5 that is driving respiratory effects. Another big piece, the gray, is home firewood burning. So that's another piece that that we devote a lot of our efforts. The yellow one here is off-road vehicles and mobile equipment. So that says to me that's another area down the road the Lung Association could get involved in and really try to clean up our air. Thankfully, we are on a road towards net zero. So net zero carbon emissions. Carbon is what we talk about, CO2 emissions. But what comes with it is a whole host of other positive effects. So we do a lot of work that I've alluded to in the electrification of transportation, because EVs mean clean air. And we're really passionate about this. We've got quite a big program on the go right now, but the federal government has committed to all new light duty vehicles and passenger trucks. So that's your half tons and smaller. So generally your daily drivers. You will not be able to purchase a new internal combustion engine after 2035. And right now in New Brunswick, we have just over 2,000 EVs on our roads. So we have come a long way in the last couple of years, but we have a long way to go. Again, thinking about towards net zero, there is this misconception in the world today that biomass or wood is a source of heat. And this is a bit of a bone of contention, but this is the opinion of the Lung Association, that the carbon that is absorbed by trees, yes, trees are great. They grow over many, many years. They pull in CO2 from the atmosphere, great. But when we chop it down and we burn it in a matter of hours, all that CO2 that has been sequestered over a number of years is now released back out into the atmosphere. So there is a lot of discussions about whether burning wood for heat is a sustainable alternative to fossil fuels. And while I would say it's maybe better than fossil fuels, the PM 2.5 effects on lung health, and we've got a nice little graphic here with some graphical depiction of how the PM 2.5 gets pulled deep into the lungs and causes inflammation right down to the alveoli level. I am more inclined to recommend that people move towards electric options, particularly in New Brunswick, where our grid is over 80% non-emitting. So electricity is a lot healthier in New Brunswick. It's become very affordable. 20 years ago, heat pumps were only for the very wealthy. They've now come down in price to the point that it is very, very doable for a wide swath of the public. So I am very adamant that from a home heating perspective in New Brunswick, lung health perspective, electric is the way to go. Again, on the road to net zero, there's a lot of, that image is really fuzzy, sorry folks. There's a lot of work towards tightening up buildings, reducing the heat that is leaking out of your home, sealing up drafts, great. Newer buildings are more energy efficient because they have less air leakage, great. But there is this double-edged sword that if it's not done with indoor air quality considerations, there could be potential for lower ventilation, particularly if you think of an old house that doesn't have any sort of mechanical circulation. It kind of relied on that breathing of the building from indoor air to outdoor air to dissipate things like moisture, to dissipate things like pollutants that may originate inside the home from a wood furnace or what have you. So as we tighten up homes from the perspective of reducing our energy costs, reducing our CO2 emissions, we also need to be mindful of the effects on the indoor air quality. So those pollutants can originate from outside, traffic, forest fires, those sorts of things, neighbors burning wood, but they also can originate from indoors. I've got consumer products listed here. That's a whole other talk in and of itself. It's another passion project of mine, is reducing a lot of toxic components in our everyday products, but also the combustion sources, your wood stove, your propane heater, those sorts of things. And also pollutants that can be naturally occurring, such as radon. I will just say radon and tip my hat to Darren, who will speak to you a little bit further in the presentation today about radon, but it's certainly a consideration, all those things, when it comes to increasing the energy efficiency of homes. And so I'm so pleased to be able to have, over 200 healthcare professionals on the line here today, and the potential to share this out a little broader with our recorded version. I have just a few minutes left, but there is a role for healthcare professionals to help in this. So climate change is what we consider a wicked problem, in that it really needs a lot of people working together across sectors to drive the change that is needed to support lung health. So if you're not familiar with the Air Quality Health Index, that's a tool that I really recommend that you get familiar with. It is a scale, it's an index that measures the contributions of a number of air pollutants. The PM that I've been talking about is one of them. And it rates the quality of the air on a scale of 1 to 10, 10 plus if it's really bad, and is actually forecasted for the coming day. So just like you check the weather, maybe you check the UV index or what the humidex is going to be today to plan your day, so too can you use the Air Quality Health Index, and so too can your patients. So we're really excited this year that Environment and Climate Change Canada have integrated the AQHI forecast into the WeatherCan app. So although AQHI has been available for a long time, and actually the Lung Association was part of the development of this this index and this tool and this messaging, we were really excited that it's literally come right into the hands of the users who need it most. I won't go into the details of the app, but it is really great. You can set out alerts. My phone pings me when the AQHI in New Brunswick is going to reach more than 3. So generally, New Brunswick, we're pretty lucky in that our air quality health index generally falls in the 1 to 3 range, which we have this standardized messaging for both the general population and for the at-risk population. So those are those living with lung and cardiovascular diseases, conditions. We can consistently, as stewards of health and stewards of environment, share this messaging with those that need it most to plan their day in a way that's going to be healthy. If you really want to get to geek out in the data with us, the Lung Association runs a pilot program with Environment and Climate Change Canada, where we have a network of citizen scientists across the province. All these circles here, we have about 37 sensors right now that measure PM 2.5 in real time and report it to the cloud. And it also shows the National Air Pollutant Surveillance System. I think the day I took this screenshot, they were offline. They are the diamonds, but generally we see them together. This map is color coded with the AQHI risk, and it's straight up the PM 2.5 concentration, so they aren't one and the same, but it is very much, we find New Brunswick is very much a driver of the AQHI. And so when the smoke rolled in from the west last year, I was literally able to watch this map. I had it open on one screen and I was working on another screen, and watch the smoke come into our province and the map light up into the yellows and oranges. So it's a very useful tool for us to be able to get out in front of the public and deliver that messaging about the protective measures that you can take for those that are more at risk from air pollution. So I did mention those living with lung and cardiovascular diseases and conditions, but also the elderly and the very young are particularly at risk here. We talk about preventing exposure. So now that hopefully open your eyes a little bit today to the effects of indoor air pollution, things like mold, things like radon. Darren will talk more about that, and the implications when we're doing things like sealing up air leaks. There's also potential for folks that are particularly sensitive or have an outdoor air source that they can't control, like a fire, forest fire, smoke, or those living nearby to neighbors that are burning wood in a very smoky way. Air cleaners and HEPA filters can really go a long way to creating a healthy indoor refuge from those pollutants. On the preventing exposures on the outdoor side of things, definitely the encouraging of alternative transportation, that's supposed to say, not transpiration, oh, pardon me, but the active transportation or public transportation that is going to reduce the overall emissions from traffic. We need to move away from one person, one car in our cities in order to really make a difference on the air quality side of things. And a program that's near and dear to my heart that we have developed at the Lung Association is Health Professionals for Action on Climate Change. And this is where I'd like to recruit all of you to join us. But what we've developed is a website portal where we have a number of evidence-based resources that pull together the social, the environmental determinants of health, the traditional knowledge that the health of our planet and the health of our humans is not separate. It's always been together, and so there's so much we can learn there. So we've got some really interesting resources there. We have created a climate change module that we have taken into nursing students programs, and I'd love to expand this into other related health professions, potentially the respiratory therapy program. Instructors on the line, give me a call later. Love to bring this into your classrooms. If you're a podcast person, we've developed a podcast series this year of a variety of different experts across Canada and across a variety of sectors discussing the intersections of climate and health. Fascinating stuff. I think we have 2 episodes live right now with more to come. And all of this lives under the banner of what Barb mentioned, our Foundation for Resilient Health, sort of a side project of the Lung Association that's very focused on the climate and toxics side of lung health. And so website there, again, I'll share, I can share these slides, but here is just a taste of what you can find over on the Foundation for Resilient Health. We have these printable or electronic resources, one-pagers we call them, where we have gone out to literature, we have collated it all together and bring together how climate and health and nature all work together, particularly in the area of, we did some specifically about climate and cardiovascular and respiratory health, children, adults, try to tailor them as much as possible to the different sectors of the health professionals that we'd like to engage here. Have a wonderful discussion with Eskinobitich Elder and Migmahan on how climate change has impacted their community. Really nice video to have a watch there. Again, the White Climate podcast. And the 2 in 20 challenge, which is an opportunity to challenge yourself to spend time in nature, 20 minutes a day, a total of 2 hours over a week. It's a very low bar, but you will find massive impacts on your health and well-being, particularly mental health. And so I encourage you to try out that challenge, try it with your team, try it with your staff. We've rolled it out over a couple of university programs with nothing but positive response. So with that, I think I did go a minute or 2 over. Sorry, Barb, we were trying to keep right on track here, but I wanted to say thank you on behalf of all the Lung Association. This is not all of our staff, but a good representation that we were able to gather for a photo. It's like herding cats trying to get everybody together, but we are so pleased and so fortunate to have the support of our community We are really proud to be an active member in health promotion across these sectors of lung health and environmental health, and how can we work together and build partnerships towards this vision of all people free of lung disease. So that's how, there's a number of ways that you can get in touch with us. Your favorite social media platform, we are active across most of the big ones. Always welcome to pop me an email. That's my contact information there. And like I said, I've got a list of some of the sources that I referenced there in really no particular order. And with that, that's it for me, folks.
Thanks, Melanie.
Thanks
It
for
was a
having me.
very interesting talk. And I remember that AQHI project. It was awesome to see it progressing. So our next speaker is Rita Berry. She's an organ donation resource nurse, and she's pre-recorded her presentation because, as you know, the healthcare sector, you never know when you're going to be called to work. So I'm going to give you a little background on Rita. She's been an RN at the Moncton Hospital for the past 35 years. Got you beat, Rita. And she's worked 29 years as a staff nurse in neurointensive care, 8 years as the staff educator for neurosciences, neuro ICU, and the rehab program, and 9 years as the organ donor resource nurse for the New Brunswick Organ and Tissue Program. So I'm looking forward to this presentation. I believe, Dusty, you're going to roll it. That might take a second. I'm not sure if people can hear me, but we are working on the audio.
Okay, so well, good morning, everybody.
There we go.
I
Great.
was asked to present on behalf of the New Brunswick Organ and Tissue Program. My name is Rita Berry, and I am an organ donor coordinator and have been working with the program since 2013. And I'm just going to share a little bit about the program and a little bit about our role within the program. We did have to record this presentation. I had hoped to be there live, and I might be possibly, but this was our best backup plan. So hopefully I answer all your questions and give you a good understanding of our program. The New Brunswick Organ and Tissue Program. So I'm going to present solely on organ, but our program does consist also of tissue and ocular. There's 3 divisions within that program. And we often have shared donors as well. So the New Brunswick Organ and Tissue Program also works, like we are actually housed under Horizon Health Network, but we work in collaboration with Particulate, Department of Health, Canadian Blood Services, and public health as well. So why does organ donation matter? Well, I mean, obviously it's a very important thing, but you know, these are just a few stats that people like. It makes it a little bit more concrete. So over 4,500 Canadians need an organ transplant at this time, and more than 250 people die while waiting on the waiting list. Organ donation saves lives. It really is the only option for these people. And tissue donation actually improves the quality of life. So, you know, that it just explains kind of why it's so important. And there certainly is more organs required than the organs that are provided and recovered. Oops, sorry, wrong way. So again, a few more things. As of July 2022, 215 people in New Brunswick are actually waiting for an organ transplant. So, you know, it just shows you how many organs we really do need. And when we're looking, I'm going to show you some of our stats, but when we look at only having, you know, 12 or 13 organ donors a year, you can see that there is a shortfall there. So as I mentioned, our stats. So in 2019, there was 13 organ donors. 3 of those donors were donation after cardiocirculatory death, which I will go over. And it was a new program that was rolled out within New Brunswick. So 10 of them were neurological, like brain death, and 3 of them were donation after cardiocirculatory death. There were 120 cornea donors and 15 tissue donors. In 2020, we had 18 organ donors, so we were up by 50%. 4 of those donors, 4 of the 18 were DCD donors. Corneas, you can see that there was an increase of 7%. Yes, so 128 donors, sorry about that. And for tissue donors, there was 20 tissue donors, so an increase of 33% in 2021. So to date, and actually that's already not accurate. So there was 13 organ donors, 3 of them were DCD donors. There's been 132 cornea donors, which was up by 3%. And tissue donors, there's 35 to date, so that's up by 75%. So as you can see, there's lots of activity within the program, and we're always trying to increase awareness and just how people can make referrals and have their answers, you know, their questions answered, you know, things like that. So there's different types of donors, as I just mentioned. So I'll go through them and try to make it as simple as possible. But and I'm sure people have heard about this before, but there are living donors. There's a living donor program. And so living donation occurs when a living person donates an organ or part of an organ for transplant to another person. And it usually is a family member or, you know, somebody close within the family. They kind of reach out to them first, but sometimes you've seen it, I'm sure, where there's like through social media looking for an organ, and they're looking for living donors. So the organs that can be donated with the living donor program are kidney, which is done in Halifax, which is our local transplant program for New Brunswick and like the Maritimes, Atlantic Maritimes. And liver. So liver, they actually would have to are worked up in Ontario, from my understanding, and liver donation can happen in Nova Scotia, and lungs are only done in Ontario. And then there's deceased donors. So there's a few different type of donors that fall within that group. So if we talk about neurological determination of death, which is we refer to as NDD, also known as brain death. Those are kind of the most common terms that are used. And these donors are maintained on life support. So death is declared by a neurological evaluation, and the patient must meet brain death criteria. And these patients can donate solid organs and tissue, so they can be like a shared donor. Yeah, so these people are actually deceased donors. And as it says right there, they are actually declared using like a neurological evaluation. So we have 2 physicians that come in and declare them brain dead. So another type of deceased donation, and I had just mentioned that earlier, was donation after cardiocirculatory death, otherwise known as DCD. And this is new to New Brunswick since 2019. It was piloted through the George Dumont Hospital at first for the first year. And it was, it's been a success. It's rolled out very well. And it's another option, for organ donation when the patient doesn't meet brain death. So these donors are maintained on life support, but do not meet the neurological criteria for death. Life support will be stopped in the ICU, and cardiac arrest must occur within a certain time frame. So it's a very planned withdrawal of care. So basically we would receive the referral, but only once the decision has been made to withdraw life support. So before they do that, then they would reach out to us. But it has to be somebody that basically has, there's no chance of a neurological recovery, like a meaningful recovery. And the decision has been made to withdraw life support on these people. And it is planned with the ICU and the OR and the transplant teams. Everybody kind of meets at the same time, and then life support is withdrawn. And if they pass away within that certain time frame, then we move forward with donation. So as I already mentioned, the first DCD donor in New Brunswick was performed in 2019. Liver and kidneys were recovered, and the first DCD lungs that were recovered were in 2020. So like I said, the pilot was started and it was kidney only, but our very first one was a younger donor. So it ended up being kidney and liver. And then as soon as we had that well established, we moved on to DCD for lung recovery. And so that's been happening ever since. And the injuries that can lead to both neurological and DCD, like a NDD donor or DCD donor, so brain death or somebody that has, no chance of a meaningful recovery, are the most common ones would be like an acute brain injury. And those are the ones that you kind of think about the most. So your head traumas, maybe like an intracranial hemorrhage, a subarachnoid hemorrhage, aneurysm that bled in the brain, a stroke, intracranial tumor, or acute hydrocephalus. And then the ones that we certainly receive more referrals for now, but wasn't quite as, people would kind of eliminate them on their own, just thinking that they wouldn't qualify. But we're starting to see more and more referrals. So these would be our hypoxic ischemic encephalopathy. So somebody that had like a cardiac arrest, so post-cardiac arrest, a respiratory arrest, so post-respiratory arrest, a near drowning, asphyxia, even hypovolemic shock. So we're starting to see more and more of those donors. It's certainly not that uncommon anymore, which is a good thing. Not for the patient, but when you're looking at receiving the referrals, that's all that is important to us, is that the family is at least given the chance, the opportunity to donate. So other things, central nervous system infection, so a meningitis, encephalitis, generalized sepsis. Don't see those as often, but it wouldn't mean that if they had that and it would led to brain death, that they wouldn't qualify. And then the ones that we really don't see too often of that list there, the ones that we've seen the most would be your diabetic ketoacidosis. We have had a few over the years, but it's not that common. And metabolic encephalopathy from liver disease, a metabolic disorder, acute hyponatremia or vasculitis. As I mentioned, I'm not even sure that I've seen too many of the others on that list. But these are all the things that could lead somebody to suffer like brain death or very close to brain death, where they're looking at withdrawing life support because they really, the injury is so catastrophic that there's no chance of recovery. So still moving on with deceased organ donation. So another one that kind of came forward with us, and it really came from somebody within the community first, which kind of, made us kind of move on it a little bit quicker. because they presented it to us. Certainly something what we had been looking at, but you know, just kind of we're made to make a few adjustments once we receive referrals, and it would be your MAID DCD donors. So we have actually had 2 to date, and currently working up another. So these are people, so donation of organs and tissues may be an option for some patients following MAID. Not all patients are eligible for MAID. Not all patients eligible for MAID will be eligible for donation. So we would have to do like a workup on these people. And donation after MAID follows like the DCD pathway and must occur within a hospital setting. So there are some things that we have to do a little differently for somebody that would want MAID DCD donation, like MAID and then organ donation. So instead of maybe if they had planned on having MAID at home, this is something that we would discuss with them. Like, it cannot occur at home. It would have to happen within the hospital setting. And, you know, the time of death might be influenced more by our program or the transplant programs. So we have those conversations. We're very honest with them. It's not the exact same as if it was planned at your home and at your convenience. But if it's something that they want and that's something that they're in agreement with, it's certainly an option. So yeah, so it's worked out well for some people, that it was very important for them to know that that some good came out of this, you know. And yeah, so then tissue donors. These patients have had a cardiac arrest and are unable to sustain circulation. So a referral of these patients are mandatory due to the Human Tissue Gift Act. All donors will be screened for tissue donation. So the way it works in New Brunswick right now is all deaths that occur within the hospital are, a notification goes to the program. So all deaths are reported within hospital. And then these people are all screened for tissue donation. In the case of an organ donor, so tissue donors can be an organ donor. We can have a shared donor, so they can, but obviously the recovery would only happen after death. So tissue donation is certainly more of an option for anybody that passes, whereas organ donation, they really have to fall within certain, you know, criteria. So the organs that can be recovered and transplanted are kidneys, liver, and that can be split, heart, lungs, and that can be split as well, pancreas, and small bowel. I think across Canada, there's even stomach out west, but it's certainly not something that's available to us, you know, locally. And for tissue donation, if somebody was interested in being a tissue donor, what they can recover is bones, tendons, corneas, heart valves, and skin. And as I said, organ donors can be a shared donor, so they could both be able to donate corneas and tissues, you know, their bones and their tendons. Yeah, so there's different options. And we do actually, when they screen the patients, there's very different criteria. So it could be that they're accepted for organ donation and not tissue. And actually even cornea is a different screening than bones and tendons. So we have 3 different kind of sets of rules. So it can be that, you know, somebody could donate organs and corneas, but not tendons and bones, and it might be a little bit confusing for families. So we try to be, you know, very honest with them, like how we're making out with the process, and, you know, why they were declined if they were. It helps them understand a little bit better, like why were they able to donate one but not the other. So it just helps them understand. So things that are important to remember or to understand are that age is not an absolute exclusion criteria, especially in organ donation. We haven't seen it in New Brunswick, although we've had some elderly donors, but across Canada, there was a 92-year-old that donated their kidneys. So as you can see, you know, there's not really an upper limit for age. For sure, the more elderly somebody is and the more health problems that they may have, it certainly might eliminate a few organs. So, and the other, thing that is really important, and we explain this to families, is that really what they're always looking at, the transplant programs, what they're always looking at is their recipients. So is it, is there a need on with their program? So it could be that we have a 92-year-old kidney donor that donates, but a week later, that 92-year-old might have not been able to donate because the need might not be there on their wait list, so the transplant wait list. So it really is all about the recipients and, is there a need for them at that time? And sometimes they just don't have the patients on a wait list. Like sometimes we've called with more rare blood types and there's nobody actually on the list at the time. So that certainly can happen. Some medical conditions that are not contraindications, because sometimes we hear that even physicians or nurses that think they might understand the program think that they're automatically excluded. So cancer is not an automatic exclusion, but it would certainly, they can't have an active cancer within the last 5 years. Hypertension, certainly we do workups and recoveries on people that have a diagnosis of hypertension. Diabetes, same thing. They might not be able to donate their pancreas or their kidneys, let's say, but they would still be able to donate other organs. Even high-risk behaviors, hepatitis B, hepatitis C. We actually even had an active hepatitis C patient, and she donated, multiple organs. Hepatitis B is the same thing, because these people can be treated. So for sure, the recipient would be notified that that the donor is more at high risk, and really it becomes about them weighing the option, and even the transplant surgeon. You need to remember, like when we basically call the transplant programs and discuss the case, they're always keeping their patients in mind. So would this work for them? Maybe they are just that sick that this is the best option, and maybe not. Maybe they're at home still, know that they need a liver transplant, let's say, but this isn't the best one for them, and then they would wait on those ones. So suitability will be determined by the health and history of the patient at the time of referral. So let's say we get calls from within the community and they're asking about certain diagnoses that they have. We always share with them that basically they would be screened at the time of death. So when we receive the referral, it's at that time that we do a workup, because let's say they have no health history at all. I could say to them, well, you definitely would qualify at this time, but then they, have a severe, car accident, and have multiple injuries, and then they're in multi-organ failure. This is just an example. So then maybe they're not suitable for organ donation, which it's not because of their prior medical history that would have been the issue, but actually what occurred at the time. So basically we always do an assessment at the time, and sometimes like post cardiac arrest, their electrolytes, all their blood work might be a little bit out of whack. Sometimes just a day or two will give them enough time to recover. We'll see that the organs are functioning better. Their labs are becoming more normalized. So something that could be declined at the beginning might be accepted, a day or two later. But anyways, so we do an assessment at that time. So if we look at the Medicare and the intent to donate in our registry, as of April 2022, within the Medicare system, 46% of people registered yes. So their intention is a yes. 36% registered that they do not want to donate. And there is still 18% that are unknown. So basically everybody's unknown until they either say yes or no. And that is, Medicare is basically an intention to donate. It's not consent to donate. It really is what somebody's intentions are. So just because they say yes on Medicare, it's still the family that consents. So we would approach the family for consent. So we always say the most important thing is to share that with your family and let them know what your wishes are. So opt out or deemed consent. So there are proposed changes to the New Brunswick organ and tissue donation legislation, and they're still under consideration, and there have been no decisions made to date. So they're looking at the same system that Nova Scotia has adopted, where everybody is basically deemed a donor, and you have to opt out of that option. So in an opt-out or presumed consent system, everybody is potential donor unless they say otherwise. Whereas right now, Medicare, the way we work is you have to opt in. You basically, everybody's unknown, and we have to kind of signal the system to say, yes, I want to, or no, I don't. Whereas in Nova Scotia, everybody is a yes, unless they say they do not want to be a donor. But again, it's still the same. In the end, it is the family that you approach for consent. So it's not first person consent. Some jurisdictions in Canada, including New Brunswick, are looking into the possibility of moving from an opt-in to an opt-out form of consent for organ and tissue donation. And I had just explained that. So like, how would it work for our program? Like, basically, how would it happen that we would receive a referral and move on to organ donation? So I'll just explain to you a little bit about our process. So the first thing is we need the referral. Like, we would need for somebody to notify us that there is a potential donor. And we do have some criteria that would, like, a triggering criteria, and we identify it as the GIVE. So G would stand for like a Glasgow Coma scale, less than or equal to 5. So this person is obviously in some kind of deep, like, comatose state. The I stands for intubated, so they'd be on a ventilator, on life support. V is for ventilation, so they're on a ventilator, on life support. And E is when they've basically had some end of life discussions. That triggering criteria doesn't always stand, though, when you look at somebody like your MAID donors, but it does help us with all the other ones. And basically, we've posted signs in the ICUs, in the ER. So, it's like, almost like, remember, if they meet this criteria, we should probably make a phone call to see if they could qualify. So then we would do a preliminary screening right there. Like, so this is just very much at a very high level, like, kind of, what's your diagnosis? What's the past medical history that you can tell me, just like, very quickly, without like looking at all the different biopsies and pathologies and all that kind of stuff. Do they have a known diagnosis of, diabetes, hypertension, IV drug use? So we just get all that information. And so we, it's kind of at a higher level. And then, yeah, they do qualify. So at this time, we're going to move forward and actually do a true, workup on this potential donor. So if the referral has been accepted, then at that time too, we support the healthcare team in doing the workup. We don't go to the bedside and do it, but we kind of instruct them of all the different information that we require for our program. So one of the most common things or demanded things are it's blood work. So we even let the families know that most of the workup is non-invasive. It's your blood work, chest x-rays, that kind of stuff. There are a few tests though that they might have to go down for that, are a little bit more invasive, especially if somebody's wanting a biopsy or so. So blood tests, like, we would find out their serology, their blood group, tissue typing, that's HLA, their CBC, like their blood counts, how are how's the liver working, how are their kidneys. So we basically assess the whole body, all their organs at the same time. Chest x-rays, ECG, we get an echo done for any potential cardiac donor. They do a bronchoscopy for any potential lung donor. And then basically there's management guidelines that we share with the staff. And our goal, and I always say it's, how hard is it? But we basically want everything as normal as possible, which they kind of, even the doctors will roll their eyes a little bit sometimes. But that's what we want. We want like a hemodynamic stability, and we want all of our labs as much as possible within a normal range. So their blood pressure, their heart rate, and this is very much the donor management and the guidelines. These are used nationally. This isn't just New Brunswick that has adopted their own. We all have, with little tweaks, you know, little differences, we all follow the same guidelines and management. So we also meet with the families, we support the families, we update the families, we explain the process, we leave contact numbers if they, you know, need anything, you know, so we let them know that they can either reach out to the staff or to us if they need anything at all during the process. And even afterwards, we would obtain consent from the family, and we also obtain like a medical social screening questionnaire. And it's very similar to when somebody donates blood. What they're looking for is any kind of high risk behavior, even, you know, it could be even like cancers, because sometimes when we ask and look on our own, or we ask the family, sometimes it doesn't really trigger, but when you ask the specific questions, they'll be like, oh yeah, you know, they were investigated for that, or I don't really know what the result of that was. So then we'll look into that. We make phone calls to the physicians, like they're a family physician. We have access to the health portal, so we'll look up all their labs, so we can see what tests were done at other hospitals. The only limitation would be if they were out of province, and then we would have to call like another organ donation program to help us. Like, is there anything that, you know, if we would call the family physicians from another province, is there anything that we don't know, that we didn't get on our own? So then the next thing that we do is we do allocation and offering of the organs. So once we have like all of our information that we require, we share it with transplant programs with the hopes of being able to allocate and, you know, recover the organ for transplant. Yeah, so that's kind of what we do in that. The process as a whole, I mean, generally we're talking from the time that somebody's declared, you know, because sometimes we'll get a referral and they're not even declared yet. So from the time that somebody would be declared and we kind of start our workup, we could be looking at, you know, 36 to 72 hours, I would say, kind of around there. Has it happened shorter? Yes. It could be a family demand, or it could be even the patient that's just not stable enough, or even if there was a high status organ on the wait list and it's the transplant program kind of pressuring us to move forward quicker. And has it gone longer? For sure. Sometimes weather. It could be extra testing that we're doing, that kind of stuff. So that's just an idea of how long it would take. And offering, I mean, you need to allow the programs enough time to be able to process all that information, and then their transplant surgeons figure out if they have a recipient that meets, you know, that it would suit well, and then they have to be able to do, you know, get the recipient in and work them up and be ready for surgery. So because basically once they recover the organ, they go back and pretty much transplant right away. So the recipient certainly needs to be at the hospital or on their way to the hospital. Another thing that we do is we do assist with the coordination of the OR, the ICU, and the transplant team. So we just make sure that the OR is aware, that the ICU knows when the recovery is going to be. We help the transplant programs. We don't book their flights or anything, but from the ambulance here. So we basically make sure that everybody meets at the same time, and that everybody has the information that they need. Another one of our roles is we are in the OR at the time of recovery, and we just assure that the labeling and packaging of the organs is done to the Canadian standards. They're very specific on that, and we just make sure that, you know, the organ is safe, that it was safe, you know, to recover, and it's safe for transplant. And that's through our workup, and then making sure that it's labeled and packaged properly. And then we have a family aftercare program as well. So we follow up with the families afterwards. When we ask for consent, we ask the families at that time what kind of information they want. We have a little list. You know, do they want a phone call after recovery? Do they want to be notified? You know, like basically sometimes there's recipients that will send letters. Do they want that kind of correspondence? And then we have like a survey and that kind of stuff. We also have like a medal appreciation ceremony that is presented to the family, but in honor of the donor. So is that something that they would like to attend, or is it something that they would not? And if they were, this has happened before where they're out of province and they're like, well, it's not realistic for us to come back to New Brunswick when we're from Quebec or Ontario. And at that point, we would reach out to the organ donor program in Ontario to make sure that they're invited to theirs, because in the end, a gift is a gift, right? They have given the gift of life, and they should be, receive a medal in honor of that. So we would share that with the other programs. So there are a lot of myths that are out there. So we'll just go over a few of them. This is Canadian Blood Services. They're wonderful, and they put all kinds of information for anybody to be able to access. If ever you want to have a look at it, go ahead. There's stuff there for healthcare professionals, but also for the public. And these are things that they kind of went out and they did surveys and all that. So I'm already registered because I signed my donor card. So even if you signed a donor card, it is your intention to donate and not consent. That's why it's important to talk to your family. I can't be a donor because I've had or had a serious illness like cancer, diabetes, and multiple sclerosis, ALS, all kinds of different ones. So despite health conditions, you still have the potential to be a donor. And as I mentioned before, all potential donors are evaluated on an individual medical case-by-case basis. So we would assess them at the time of the referral. Organ donation will affect my funeral. So organ and tissue donation does not generally disrupt funeral plans. It might delay them, but they can still, if they want an open casket, that's still an option. They certainly, it just might delay it. And we've had families come forward before where, they already planned, because they had been ill for a little bit and they really wanted the funeral on a certain day, and they're afraid that it's going to interfere with the dates. And at that point, we would present that to the transplant programs and tell them that there is a timeline. And they respect that very much. Like in the end, if not, then there's no organs recovered. Like we didn't kind of do our job. So they're very respectful of family wishes. Families have to pay for organ donation, like the transfer. So organ donation does not cost the family anything. So basically, if they were transferred to another facility for organ donation, that would be covered by Department of Health. So we let the families know that, like, if you receive a bill from the funeral home or for, the transfer back, you let us know, because we will certainly look into that and help them get that paid. There's no way anyone would want my organs. I'm too old. So we already talked about that. If I sign my card, doctors won't work as hard to save my life. We hear that a lot, believe it or not. The first concern for any healthcare professional is to do everything possible to save lives. Indicate your intention to donate does not have any impact on effort made by healthcare professionals to save your life. And that is true. Like when somebody comes through the ER, if they're a cardiac arrest or they're a trauma, their first job that they're always going to do is try to save their life. They're not looking through their wallet to try to find their Medicare. We don't know that till after. And actually, even if they wanted to look at somebody's Medicare, like if they didn't know and they don't have their card, it's not like physicians or even people in the ER can just look that up. I can, because I'm a coordinator, but very few people have access to that. So it's simply not true. Like our first goal always is to save someone's life. And that's actually the end of my presentation, since it was, we were restricted. I could go on for days, but we were restricted to 25 minutes. So I did try to present that as quickly as I could. And if I'm live, I would certainly take any questions at this time, but unfortunately, I am recording because I'm not able to be there. So if you do have any questions, you can certainly email them on to, like, everybody has our contact email, and Barb and knows how to get a hold of me. So we could, I would have to do that more by email, but I can certainly answer any questions that you have. And you can call our program. We field calls all the time from the public. And it would be the 643-6848, and it's a 24/7 number, and you just leave a message with the answering service and we would return your call. So I'll take any emails or any calls. And I hope that this was helpful, and I hope you enjoy the rest of your conference. Thank you. Bye.
Hello. Well, I feel like I'm on one of those trains where the brakes have failed. So we are going to be still moving along quite quickly. As you know, we've skipped one break already. I want to mention a couple housekeeping items. The subsequent speakers, I have texted you to make sure that you're still okay with the fact that your presentations are now running behind about 10 or 15 minutes. So you could just text me back. I want to quickly mention that the New Brunswick Lung Association for the past 12 years, I created a lung transplant support program and a Facebook page, and we've helped 139 New Brunswickers over the last 12 years. If you're interested in knowing more about our program, you can email me. I have a quick fact sheet. And in light of what Rita was talking about, just since 2019, we have lost 8 of patients waiting for transplant. And this summer alone, 4 of those 8 died waiting for transplant. So Rita's presentation is very important. Our next speaker, speaking about our tobacco-free New Brunswick program, is Melissa Smithers. She's the team lead for the Tobacco-Free New Brunswick Quit Line and has been working in the smoking cessation field for over 10 years. She graduated from Western University in 2006 and pursued a career in addiction counseling. As a lifelong learner, she completed her master's degree in social work in the fall of 2020 and is a registered social worker. Melissa is passionate about helping people with their behavior change goals and enjoys her role leading a team of quit coaches to provide the evidence-based approaches to several quit lines across Canada. Welcome, Melissa. The floor is yours.
Great. Thank you so much for that warm welcome, Barbara. It's great to be here. I will share my slides for today. Okay, so I think I'm sharing okay now. So I'll get started. So I'm going to be speaking about the missing piece, Tobacco-Free New Brunswick program, and very important tool in smoking cessation. So the goals for my talk today are, hopefully at the end, our objectives will be to be able to describe the program and services that we offer at Tobacco-Free New Brunswick, to explain our care coach approach to tobacco cessation, and discuss the ways that you can refer your patients to our program. So just to set the stage a little bit about tobacco and vape use in New Brunswick, the current rates or the prevalence for tobacco use, about 14% of people in New Brunswick over the age of 15 are current smokers or currently smoke, and about 6% of youth aged 12 to 19 years old currently smoke. When it comes to vape use, there's about 9% of New Brunswickers who have reported vaping in the past 30 days, as well as when it comes to youth, we do see a higher number. So about 16.7% of youth aged 15 to 19 have reported trying e-cigarettes. So this is sort of showing that there's still many people out there who we're looking to support in their behavior change goals for tobacco and vape use. So as I go through the next few slides, keeping in mind that our program does support people who are using tobacco, but also using vape or e-cigarette products as well. So an overview of the programs that we offer, we have 5 different programs or services that people can choose from. They can choose one, or they can choose all 5 when they enter into our program. So we offer over the phone, text support, online support, live chat, and also some e-quit tips. And I'll go into more detail on all of these programs in the next few slides here. So when it comes to our phone support, Our quit line, it offers free, confidential, non-judgmental support from our trained care coaches. We do offer translation services, so there's over 300 languages that that we can provide translation for. So that's helpful, but all of our care coaches are bilingual. So anyone who's calling in can have services either in French or in English. And we're available Monday to Friday from 9 a.m. To 9 p.m. Atlantic Standard Time. So when someone first calls into the quit line, we go through a series of standardized questions just to assess for their current and past tobacco or vape use. So we get an idea of kind of where they're starting off. And we also, at that point in the first contact, will recommend a self-monitoring tool so that people can start to track their use, what time of day they are smoking or vaping, what's happening for them at the time, a certain activity, if they're around someone, their mood, and how intense the craving is. So that really helps the person and the coach for that first scheduled call to explore their smoking habits and set up a plan. So at that point, the person is assigned their own care coach who follows them throughout their journey. So they'll speak with the same person each time. And I'm going to go in more depth into our approach over the phone and through all of our interactions with people a little bit later in the presentation as well. But we also offer text support. So this is a 3-month text messaging program where it delivers motivation, advice, and tips. And each message is really tailored around someone's quit day. So say if someone signs up for the services a few weeks before their quit, they're going to get probably one text message each day, just helping them to prepare for that quit day, you know, getting rid of reminders about cigarettes, ashtrays, lighters. So little tips along the way that will help them feel more prepared for their quit day. And as that quit day approaches, they might start to get 1 or 2 text messages a day, just helping them through that time, and then messages after their quit date as well. So over that 3-month span. The nice thing is if somebody doesn't have a quit date, we can still help them. So that's no problem. They would text the word thinking, and then they'll get text messages more around how to feel more prepared to set a quit date, or how to work through some of the ambivalence that people feel when they're preparing to quit. Like, you know, I sometimes like smoking, but I know I should quit, and kind of work through some of those feelings. So that's what the thinking part of the program is all about. For anyone, they can sign up for the text message program by starting a new text message, text the word smoke-free NB, all one word, no spaces in between, to the number 123456. So nice and easy to remember. Or they can also go to the website, which I'll talk a little bit more about, and they can sign up through the website, put their cell phone in there, and start getting text messages. So a few different ways to sign up for the text message support. Online support. So we have a really great website, very comprehensive, internet-based service available that's free of charge for all residents in New Brunswick. So there's lots of information here. People have access to tons of information to help them stay motivated and plan their quits. There's information on how the body heals, how to set a quit date. They can list their triggers, you know, times of the day or situations where they're more likely to smoke, their reasons for quitting. There's tips on how to conquer their cravings, deal with stress. So all of these great topics. There's tools to track progress as well, so people can create their own count, and it will show the number of days, months, years that they're smoke-free, which is very encouraging, how much money they've saved, and they'll have access to their personal plan, so they can see what their triggers are, what their coping strategies are. They can always go back if they want to review any of their quit plan. There's also checklists. So before, how to prepare before a quit date, you know, they can print it off, check off some preparations. There are checklists for an actual quit day, what to do on the quit day. So it really helps people stay on track. There is also a tobacco tracker So this is where people can go in and track their urges. They would say, okay, it's 4 p.m., feeling kind of sad. I just got home. They can put in all these details. And over time, the more that they track these urges, the website can deliver analytics to show, okay, I'm more likely to crave at 4 p.m. or 8 p.m. and help to target those times of the day. So lots of options there. There's also milestone certificates, so people can go in and choose as many as they wish to print off, put it on the fridge, recognize their hard work with their quit process. So they can print off certificates for 1 week, 3 weeks, 1 month, all the way up to the first year. And then from there, each year up to their 10 years smoke-free. So just another nice way to celebrate and reward for their quit process. Finally, through the online support, we have community forums. So this is where people can gain support from peers, other people who are engaged in their changes as well as from the care coaches. So I took a little photo here off to the right of a real interaction. So I kind of blocked out the person's personal information, but they're just sharing, hey, I'm really happy. I've been smoke free, and we can see the quit coach has gone on to congratulate and encourage that person to continue. So it's a great way to have that interaction. Sometimes people feel like, oh, I'm doing this alone. You don't have to do it alone. There's lots of other people out there who can, encourage you along the way. And it's 24 hours a day that they can go online too. So it's a nice way to stay connected no matter what time of day it is. Our live chat is also through the website. So this is where people can have that real-time quit advice with the care coach. Once you get to the website, it's just in the lower right-hand corner of the website. Click on Start Chat. You can write in a question if you have a question, or some people just say, hey, I just quit, or I'm just preparing to quit. What do I do? How do I get started? So any questions there, it's a nice quick way to connect with the care coaches. Again, this is Monday to Friday, 9 a.m. to 5 p.m. at this point that they can log into the live chat service. And finally, the e-quit tips. So these are emails that contain helpful tips and strategies to quit smoking or stay quit. They're also tailored around a quit day. So similar to the text support program, where they're going to get some preparation emails beforehand, and then how to stay on track after their quit day. Sign up for this is also through the website. And the message frequency can change depending on their stage of change, if they're in a preparation or maintenance, or if they're in the action stage. And we'll go over stages of change in a little bit as well. So when it comes to our care coach approach, how do we approach people who are making changes? There are 3 main evidence-based practices that we use to connect with people, to help people make their behavior change through tobacco or vape use. So we use motivational interviewing and that person-centered approach. We also use the stages of change model and a case management approach as well. So motivational interviewing, I tried to summarize motivational interviewing in just 1 slide, but if anyone's taken any courses on motivational interviewing, you know that this could be a full course in itself. So this was my attempt to narrow down motivational interviewing. It was developed by Miller and Rolnick, and at its core, it's really meeting people where they're at in their behavior change journey. So when people come to us, we're going to be right there with them. We're not, we're just going to listen and hear, and really they're the experts in their own lives, is, I guess, the core of this approach. So it is an evidence-based approach to smoking cessation. It is shown to enhance motivation to change. It's also a way of building rapport with people, which we know helps people also make changes when they're feeling like they have a nice relationship with their coach. So it is a way of communicating respect and acceptance for where someone's at, and it helps to to give people hope and also to build their self-confidence or their self-efficacy to change. So the spirit of motivational interviewing here with the 4 circles, this is one of the acronyms, one of the many acronyms in motivational interviewing, which is sometimes you may hear it described as PACE, P-A-C-E, or CAPE, C-A-P-E. So it's that partnership that we're developing with people, really that collaborative approach. We are accepting people where they're at. If someone is not ready to change, we're with them in that moment, exploring, reasons why they don't want to change and maybe reasons why maybe they could want to change. So being very accepting of where they're at. It's very compassionate. We're expressing a lot of empathy in the calls for where people are coming from and what their challenges might be. And we're also evoking from them, what are your reasons? What would be the next step for you? So again, they're the expert in their lives when they come to see us. And we're the guide, I guess, so to speak. So applying motivational interviewing to the stages of change. So as I was mentioning, people can come into the quit line at any of these stages here. And if you haven't heard of stages of change before, it was developed by Prochaska and DiClemente. And so pre-contemplation would be someone who is not aware or they're not sure that they have a problem. So their tobacco use is not necessarily a problem to them. And they don't intend to take any action or changes within the next 6 months. If somebody is contemplative, they are aware that there could be a problem and they might be thinking about change. They may even be intending to change in the next 6 months. So this is often where we'll see people more so in contemplation who are accessing the quit line, who are saying, I'm thinking about making a change, not quite sure how I would do it. I'm a little bit ambivalent still about it. So we would help move people around, into that preparation stage. So in preparation, that's where some people are already starting to take steps. Maybe they're reducing their tobacco use or they're delaying their first cigarette or any cigarette of the day. And they're intending to change within 30 days. So they might have a quit day within 30 days of speaking with them. The action stage, that's where someone has made specific and modifications to their lifestyle or to their tobacco or vape use in the past 6 months. So we believe people are in that action stage for 6 months. So there's a lot happening in those 6 months of maintaining the changes. So at the 6 month mark, that's usually when we think someone's in the maintenance stage. They've kind of moved past the action of implementing their changes. And I added relapse off to the side because relapse is one of those things that can happen at any point in the stages of change here. And if someone experienced relapse, they may go back to contemplation, or they may go right back to action, or and that's something that we really normalize. Like, relapse is part of the process for a lot of people. I know we don't want it to happen. It can be quite upsetting, but it's a great learning opportunity at the end of the day to say, what's not going so well, and how can we put some systems in place for that next attempt to make you feel stronger, or make you feel more confident in your process. So we can make it, as hard as it is, we can make it, that normalize it in a way and validate someone's experience with relapse. Finally, the case management approach that we use. So once someone comes into the quit line, we do assign them to work with the same care coach throughout their journey. So, on average, people usually get about, I would say, 5 calls. I know everyone's process is a little bit different, so it's hard to put a number on it. But often people have a couple calls before their quit day to prepare and set up that quit plan, if they'd like a call on their quit day. And then a few calls after to follow up, 1 week, 1 month, a couple months down the road type thing. So it's nice because each of the phone sessions can build on the previous session and build on the client's plan. So the coaches, and the clients, they really get to know each other. The coaches can assess for strengths, for challenges in each session. And it does help improve outcomes because there is also that relationship that's deepened. There's more trust that's developed. So people may be more likely to share their barriers that they're looking to overcome when they're feeling like they're in a trusted relationship and speaking with the same person. The other thing is the care coaches can provide referrals to other community resources and support. So if somebody's talking a lot about, maybe they're coping with other things in their lives, mental health or health, anything, we can provide those referrals to connect people to other resources. The advantage of our approach or the quit line in general, I guess, is there is a lot of research showing that phone counseling does increase quit rates in people who smoke. And it is also that approach that I was mentioning, that non-judgmental support of meeting people where they're at, where people they feel a bit more relaxed. They can, they can really share when they're feeling like they're in a safe space to share things. So that non-judgmental approach really helps to meet people where they're at. And that the partnership that's developed where we're communicating acceptance and respect. So there's no pressure from the care coaches. And a lot of times when people aren't feeling that pressure or being told what they should do, the clients themselves are coming up with their reasons for change, with their goals. They're more likely to follow through, really. And we're there to, say, okay, here are some options. What fits best for you? So it's a really genuine and compassionate approach from the coaches when someone comes into the service. So what is the missing link? It is the connection between healthcare providers like yourselves providing referrals to your patients to connect with us at the Tobacco-Free New Brunswick Quit Line. So when you are asking, advising, and assessing for tobacco or vape use, just to remember our services are here to help further connect and support people through their behavior change goals and their journeys. We know that when someone has an interaction with a healthcare provider, so, a respiratory therapist, a nurse, their doctor, they are more motivated within that day or two to make changes. So when somebody calls the quit line or they go on the website, we are getting them an appointment with one of our care coaches within 24 to 48 hours. So we can kind of pick up and support that person with some additional information and planning very quickly. So yeah, it's a nice way to connect people and just add that extra layer of support. So again, referrals can be made either to the English line or the French line. There's no wrong door though when it comes to the toll-free numbers. If someone would prefer their coaching in French and they call the English line, that's no problem. But there are the two separate lines there, as well as the online, the website where people can sign up for phone support, text, chat, e-tips, and all the rest. So I can take any questions about what I've discussed so far.
I think at the moment there are no questions.
I'll ask a
However,
question.
oh, hi, Neebun.
Hi. I was just wondering, what about, is there any statistics on marijuana use where it's legal now in Canada? Like, I was just curious.
Yeah, that's a great question because right now through the Quit Line, we don't actually coach for cannabis, but it can be common. So if someone is just making changes with cannabis, we would likely provide a referral to another resource because that's not something that we coach for at this time. However, if someone is using tobacco or vape and cannabis could be a trigger, that is something that we can speak towards it as a trigger, but we would likely provide a referral to another resource for cannabis at this time.
Oh, there is another question. Shannon asked, can we get cards or something to give to their patients?
That's a great question. Right now, we don't have print materials for the program. Yeah, we don't have them at this time, but that's a great question, something I can take back to the team.
Okay. In the past, people who, this may be to do with, remember there was that name thing you and I went. In the past, people who had a phone number from outside of New Brunswick, when they called, they would not be directed to the NB quit line. Has this been fixed? I'm not quite sure if they're outside of New Brunswick and they.
So if someone is outside New Brunswick, so say someone from Nova Scotia calls those numbers that I listed, they would actually be directed to the Nova Scotia quit line. Right. So basically those are the Canada-wide numbers, and no matter where someone is in the country, they'll be directed to the appropriate quit line. So if someone from New Brunswick moves out to BC, they would be directed to the BC quit line. So I hope that helps.
Yes, it does. Yeah. This is just off the top of your head because we won't have time for you to go back and dig through your files. What is the volume of people who access support through the quit line each month?
Each month, okay.
I know. Thanks, Shelley.
You know, I can just speak, I don't have the actual statistics, but I do keep an eye. You know, we might have, I would say, maybe, how many would we have? We probably have a few new enrollments each week. Maybe about 5 to 10 new people who are enroll in coaching and are going to start engaging in the coaching process. I would say 5 to 10 each week.
One of the things I really like about your program is probably about 10 years ago, I did an in-person support group program, and that's what I like about yours. The one-on-one makes such a difference to have someone help you with quitting smoking, and so it's wonderful to have this kind of a program available for people. I think we probably all know someone who would like to quit or would like to quit themselves. So in the interest of time, again, thank you very much, Melissa, for your presentation.
Thank you, Barbara.
So we're going to move along. And so we've pretty well blown our any time for a break. But once again, if you need to step away from your computer, the symposium is being recorded. So our next speaker is Darren Tarr, and he's going to be speaking on radon gas in New Brunswick, and it is a really vital topic as well. I'm sure Darren will probably mention that I think we have quite a high, when you look at a map of New Brunswick, it's shades of orange. So Darren is the supervisor of the Industrial Hygiene Air Quality Laboratory at New Brunswick's Research and Productivity Council in Fredericton. He attended the Nova Scotia Agricultural College, Dalhousie University in Truro, Nova Scotia, obtaining his degree in environmental science agriculture. He joined RPC's Process and Environmental Technology Group in 2008 and eventually found himself interested in the air quality side of the business, leveraging a move into that sector of RPC. Since that move, Darren has been helping people with their air quality concerns and questions. So take it away, Darren.
Perfect. Thank you very much, Barb. I'm just going to make sure this works before I... Does that look good, Barbara?
I believe so.
Perfect.
I think Dusty would say something too. I see a full screen, so.
Perfect. That's awesome. No, I tried it this morning and it didn't quite work right. So anyway, I'll get right into it because I know we're on a time constraint here. I'm actually going to set my timer because I was doing it last night and it was I was hitting 30 minutes, so I'll try to speed through this. Welcome, everybody. I'm going to talk a little bit about radon in New Brunswick and what radon is and such. So I guess the first thing we're going to talk about is what is radon. So radon is a colorless, odorless, and tasteless radioactive gas. So it's naturally produced for the decay of uranium. It can be found it's found all over Canada, all over the world. It's everywhere. So the thing with radon is that it can't be detected by your senses. So people can't see it, they can't smell it, taste it. They don't know it's there. The only way you're going to know it's there is if you test for it and see what you have in your home. So I think that's a big thing in people's minds. I know we were doing a conference a little bit ago, and we were giving out radon kits, a draw for free radon kits, and I think there was 10 free radon kits, and the people who we drew to win the kits, we called them up to come pick them up, and then nobody wanted to know about them. They said if they don't smell it or hear it, then they don't have to worry about it, which isn't correct. So you definitely need to find out if you have high radon in your home. So radon is an inert gas. It's not chemically bonded or attached to any other materials. And that allows it to easily move through small spaces like soil pores and cracks in the foundation and such. So radon produces radioactive decay products, radon daughters through ionizing radiation. So with radioactivity, pronouns, neutrons are held together by nuclear force. And radioactivity is the result of the instability of some of the nuclei, where there are too many or too few neutrons to satisfy the energy relationships within the nucleus. This will lead to radioactive decay, which is disintegration of the nuclei of atoms in a radioactive element. These disintegrations are usually accompanied by the release of energy. So as the nucleus of an atom releases these particles of energy, changes the nucleus into a different atom. So ultimately there's a decay chain. It starts with uranium. There's several immediate steps to produce radium and radon. So radon, it has a half-life of 3.8 days. So therefore, every 3.8 days, you have half as much. Another 3.8 days, half as much. So essentially, it's there forever, but it'll eventually get down to where it's minimal or negligent. Half-lives are important because it determines the availability of radon and its decay products to be dispersed into the environment. So with radon being an inert gas, it can travel quite far through the soil pores in 3.8 days, and that allows it to enter people's homes relatively easy. The issue with radon is radon daughters, and it's the shorter half-lives with the first few radon decay products. They can allow considerable amounts of radiation to reach the inner lung surface before they're removed by the lung's natural cleaning process. Some of these shorter half-lives include polonium-218, which is about 3 minutes half-life, polonium-214, which is less than a second, and lead-214, which is 27-minute half-life. Okay, so the properties of the radon decay products enable them to easily attach themselves to solid objects such as dust, smoke, and surfaces in the home, such as walls and floors. If the radon decay products attach to surfaces or walls, they're said to be plated out and they're no longer airborne. However, if they attach themselves to dust or smoke particles, they can be carried quite deep into the lungs, where they can lead to cancer of the lungs. So quick little tidbit here. So why is radon here? Basically forever. So uranium-238 has a half-life of about 4.5 billion years. The Earth is approximately 5 billion years old. So right now there's approximately half the uranium that's remaining since the Earth was formed. So it's pretty much here to stay. Here's just kind of what Barbara mentioned about radon levels. It's a radon map put on by Health Canada. You can see essentially New Brunswick is in the red. It's got some of the highest levels. And you can see how it changes. Like it's not constant all across Canada. It's naturally present in the environment, and there's actually radon outdoors. So they estimate around 10 becquerels per meter cubed average outside across Canada. Normal ranges, I'd love to see everyone be doing 30, 100, low in that range, but obviously that's not the case. So in Canada, we measure radon in becquerels per meter cubed. In the United States, they measure it in picocurates per liter. So the conversion is 1 picocurate per liter is equivalent to 37 becquerels per meter cubed. So in 1988, they put a guideline of 800 becquerels per meter cubed in place. But then there was some more evidence of surrounding lung cancer cases in individuals who didn't smoke. So it was recommended that the levels were dropped to its current 200. So as I mentioned, Health Canada recommends in Canada having a radon level lower than 200 becquerels per meter cubed. And they also implemented these kind of go by ads, like, I guess if it's under 200 becquerels per meter cubed, they say it's good. If it's between 200 and 600 becquerels per meter cubed, they recommend remediation within 2 years. And if the levels are above 600 becquerels per meter cubed, remedial action should be conducted within a year. So there are other recommendations to these levels. The World Health Organization recommends a level of around 100 becquerels per meter cubed, while the US recommends a limit of 4 picocurates per liter, which is equivalent to 148 becquerels per meter cubed. And just because you're below the 200 becquerels per meter cubed recommended limit doesn't necessarily mean that you're safe. I mean, the lower you can get, the better it is. So indoor concentrations will vary due to a variety of different factors. For example, seasonally, so typically your radon levels are higher in the winter months. There also fluctuates daily, and they tend to be higher in the night and the early mornings. Weather conditions will also impact radon levels. They may be higher in higher wind events, rain, or snow. And they're generally a lot in the lowest level of the home. They're higher levels. So basements, crawl spaces. Doesn't necessarily mean that they're always going to be higher in the lower levels. If there's a direct route from say there's a pipe going from your basement directly upstairs, then you might have high levels as well in the upper levels of the home. So there are some obviously known health risks associated with radon. Radon's a carcinogen, and it's definitely shown to increase chance of getting lung cancer. We're actually seeing more people call in, and they're sharing stories with their family members who don't smoke, who are developing lung cancer. So it's very important to test. Actually, radon exposure is the leading cause of lung cancer in non-smokers. And smoking has been shown to cause about 90% of lung cancer deaths, and radon has been directly linked to 16% of these deaths. Your risk level is going to depend on a few different factors. The radon concentration, obviously you need a source. How high is the radon in the home? The duration that you're going to spend time in the home. If you're in the home all the time and not going outside, then that's going to increase your risk level, as well as your smoking habits. If you smoke more or less, that's also going to increase your risk level. These are 2 different quotes. I think they're great. I'm just going to read them off here from Health Canada. Health Canada estimates a non-smoker exposed to elevated levels of radon over a lifetime has a 1 in 20 chance of developing lung cancer. The combined effects of radon exposure and smoking tobacco significantly increase the risk of lung cancer. If a smoker is exposed to the same level of radon over a lifetime, the risk will increase to a 1 to 3 chance. So it's very, very important to consider. Obviously testing your home for radon, and if you can quit that smoking, it's also a good thing to do. So what are some radon influencers? So some things that influence the amount of radon in your home are your soil characteristics. So you have a high uranium content in the soil beneath your home or in the soil surrounding your home. Also soil type. If you have a more permeable soil, the radon gas is going to be allowed to venture up a lot easier than, say, you had a more of a clay-based soil under your home. The home construction, the design of the home. So if it's a bungalow or something, you get less contact to the the ground to the foundation, or if you have a 3 or 4 level split, then you might have a little bit more surface area touching the ground. That would allow radon to enter your home. Foundation condition, if there's cracks in your foundation, if it's starting to degrade, that sort of thing, that will allow more radon into the home. Your occupant lifestyle, if you don't close your windows and you like to keep that cool air in, that's going to trap all that radon gas inside. If you run your fireplace all year round, or not all year round, but in the cold winter months, through the cold winter months all the time, you're going to also could possibly increase the radon amounts, and running exhaust fans and such, as well as temperature. Sorry about that. Temperature, wind, barometric pressure, precipitation will also increase that. So this is kind of a pictorial on how a radon will enter your home. It can enter through fractured bedrock. You can get it through the groundwater. It goes in through cracks in the foundation here. Sump pumps, that sort of thing. I'll go through quickly because I know we're running a little low on time. Also in crawl spaces, if you have exposed dirt floor like up in here, any pipes coming through the foundation below grade, that sort of thing, as well as block walls. You got lots of mortar in between it is starting to fracture and degrade, then you have more options of radon entering your home. So how is it entering your home? So there's a few different things. Materials. So sometimes people get granite countertops. If there's your high uranium content in the foundation when they're making the concrete, that could lead to a little bit of radon entering your home, as well as in groundwater. It will diffuse into the well, and as it releases in from taking showers and stuff, you could increase the amount of radon going into the air. Diffusion from high to low pressures, as well as pressure-driven modes of transport, and those are the most dominant. You can test your water and your well for radon. That's not really recommended because basically it's the problem with in the water is when you're showering, it's being aerated, it's being displaced into your home into the air, and that's really the issue. So. Okay, so air pressure differentials. So radon entry by pressure-driven airflow from real grade are the most dominant form of entry into a home, and they play a key role in movement of radon gas. So negative pressure is when the air escapes from the home, which is known as exfiltration. Air pressure differentials between the inside and outside spaces are created. This will result in the air being pulled into the house, infiltration, to replace the air that was removed. So when the lower portion of the home is depressurized, makeup air will enter the home through cracks and holes in the building structure. Also, indoor-outdoor temperature differentials. When the air is colder outside than inside, the lighter air will more typically rise to the top of the building. This causes the lower portion of the air in the building to depressurize, drawing in makeup air. These airflows due to cold temperature differentials are also called convective airflows. Another mode of entry to increase the radon is as wind. So it'll create a complex pressure field essentially around the home. It creates a positive pressure in the soil on the windward side and could increase the gas entry from that side of the home. One of the other big ones is mechanical equipment. So furnace blower, so you're taking air from one spot and displacing it throughout the home. That's going to change the pressure inside the home. Exhaust, bathroom fans, kitchen, you're taking that air from inside the home, displacing it outside the home. So it's got to find that makeup air somewhere, and if it's coming into the cracks in the foundation and such, then you could have a more apt of having radon gas enter your home. Some other environmental factors that could increase it, I should mention, are water factors. Rainfall, so spikes, so we noticed some spikes in radon levels due to rainfall filling the soil pores and blocking the gas naturally. We did some testing here. We have a continuous radon monitor, which I'll talk about a little bit later. And that monitor, we watched it, it started ringing outside and it lifted the radon levels in that room within an hour, probably another 100 and some becquerels just from a little shower. So another water driven is hydraulic pressure. As the water table rises underneath your home or surrounding your home, the water will redirect the radon movement into the soil, and gases will be forced to go towards the home's foundation. And as well as snow and ice will essentially do the same as rain, and will cover and encapsulate the ground, redirecting the soil gas movement into the home. So there was a cross-Canada study done, and it was just basically looking at the percentages of homes in Canada that were above 200. So approximately 7% of the homes in Canada have high radon, and New Brunswick is one of the highest in Canada at 20.6%, followed by Manitoba at 19.4, Nova Scotia at 10.6, PEI at 3.5. So yes, radon is very prevalent in New Brunswick, and the only way you're going to know is to test for it. So these are some of the most popular testing devices that are available. There are other testing devices, but radon electrets are one of them. So you can conduct short-term and long-term testing with the electrets. So essentially the ionized radon or ionizing produced by the alpha particles will reduce the voltage charge. So the discs on these have voltage applied to them as the radon enters inside the deployment cap. It drops the voltage, and then that voltage is used in calculating the average radon result. Another testing device is an alpha tractive detector, sorry. So air will enter the chamber, and the alpha particles will actually impact the plastic, and that causes damaging tracks on that special plastic. And then the number of tracks is proportional to the radon concentration. So we can identify what the average radon level is by analyzing and counting those tracks. Another device that's being used now is a continuous radon monitor. They're very easy to use. Most of the time you just set it down and press play, and it'll equilibrate and give you a radon result. The results are fast. On this one here, this is a Radon Scout. It's red right on the screen at times. It offers continued monitoring, and some of them are Wi-Fi enabled, so you can actually access that and get reports as it's being monitored, I guess. But the question is, are they CNRPP certified? There's lots of different things, lots of different monitors out there, and you just want to make sure that they've been tested and checked by the CNRPP, which I will get to a little bit later. This is basically a pictorial of the continuous radon monitor. This is from our lab here at RPC. And you can kind of see this is taken over, I believe it's a 4-day period. And you can see the fluctuations in the radon levels. I believe it started to rain on the 8th of August a little bit, and that's why we had that little bit of a spike there. But it kind of gives you an idea of how radon will vary throughout the day and throughout the week. So short-term measurements. So short-term measurements are basically an indicator. They've been known to overestimate and underestimate the amount of radon that is in a home. So you shouldn't base any remediation efforts on a short-term result. You should always do a long-term result and after a short-term result. There's different testing. So when you're going to set up your test, you're going to want to make sure you put it in the right spot. So you need to decide, is it going to be a short-term or long-term test? I always try to push people to do the long-term test. This is a better test and gives you a better, more accurate result over the 3 months rather than 2, 3, 4, 5 days. You're going to want to test in the lowest level of the home where you spend at least 4 hours of the day. For short-term tests, closed house conditions, we try to keep your windows closed and such, your doors closed. Your placement of the detector, so you're going to want to put it like 0.82 meters off the floor, 3 to 6 feet, 40 centimeters from an interior wall, which is 16 inches, 50 centimeters from an exterior wall, which is 20 inches, or 8 inches, 20 centimeters from other objects. And you can also hang them from the ceilings. You want to put them in a location that's not disturbed. Just don't place it near any HVAC systems, electrical. Don't place them in any bathrooms, kitchens, laundry rooms, sump pumps, just places where you wouldn't spend much time. You want to put it in an area where you know that you're going to be spending lots of time. Okay, so with real estate transactions, some things popped up where people were getting tests done, the short-term tests, because there's not enough time to do a long-term test. And basically you can't take and take a radon result from a short-term test and use it as a remediation effort. So the CARST came up with a real estate testing plan, a real estate radon screening assessment. And this assessment should be conducted prior to any real estate transaction unless a long-term test has already been conducted within the 3 years. The minimum duration for a screening assessment is 4 days. It's a better comparison to the average level of radon in a room to try to leave it those 4 days. So they came up with green. So if the green result is achieved, and the green is 75 becquerels per meter cubed or less during the heating season, or 50 becquerels outside the heating season, there was no further recommendations for anybody to do any further testing, not testing, but negotiation, I guess, in the home sale. For a yellow result, if it's greater than 75 during the heating season or 50 outside the heating season, up to 400 becquerels, it's an indicator that there's likely the average radon results is above the 200 becquerels and possible action, further actions required. And red, if it's greater than 400 becquerels, it indicates there's a likelihood that the average radon result is going to be above 200. That's when purchase negotiations would take place to maybe include the potential cost of a mitigation system, where maybe money would be set in escrow and a long-term measurement would be set up to be conducted, and that would be included in the home sale. As if there's high radon, then the money would go towards the remediation system. If everything was below, then the money would be released back to the seller. This would require many estimates, and now getting a written estimate on the cost of a radon remediation system. But regardless of any result from the screening assessment, you need to do a follow-up long-term test to make sure that that is correct. So if you do a short-term, you always have to follow it up with a long-term test. So one thing that happens sometimes is tampering. So there's different tampering aids you can add to your radon kit. There's tamper tape. This is a tamper-proof box that holds short-term tests. And you can also put on special zip tie with special number, which would be recorded, and you can actually go back and see and make sure that no one's changed them out. Some of the continuous radon monitors have movement sensors. So if the unit's picked up and moved, then you know that the results might be not correct and somebody has messed with the test. So those are a couple things that are important when doing home sales. What if radon is present? So you need to take action. There's several different remediation techniques. These remediation techniques can reduce your levels up to 80%. We've seen very good results from before and after testing some of our clients. They're actually very low cost to implement these removal systems. Most of them are very cheap. Maybe the cost of a small renovation or replacement of a furnace or an air conditioning unit, between like $3,000 to $5,000, depending on how many wells you'd have to input in, and we'll cover that as well. And they should also give quick concentration reduction results. So it doesn't take long when they get the system up and running to bring those radon levels down and below the 200 becquerels that's recommended. So some of the remediation techniques involve there's soil depressurization techniques, ventilation methods, so ventilating crawl spaces. You can also close entry routes, some pump covers, filling in cracks in the foundation, pipe chase gaps or voids, as well as installing special drains to prevent radon from coming up into the home. The most effective and reliable is the active soil depressurization. So the subslab depressurization. So essentially, they'll drill a hole in your foundation floor, and a pump or a fan is running constantly, so 24 hours a day. Essentially, that's dragging all the radon gas from underneath your foundation and exhausting it outside the home before it can actually enter your home. Some other remediation techniques include sump pump hole. So sump hole depressurization. So if your home has a sump pump, sometimes they can render and use that as a evacuation method to hook their system into. Drainage system depressurization. They're used in homes that have enough drain tile. It surrounds the home, and they can actually tie into the drain tile and exhaust the radon that way. Another one is submembrane depressurization. So that would be used in exposed dirt floor situations or in crawl spaces where they basically put a plastic barrier down and use that as a barrier to exhaust the radon and hook their fan in that way. A few other methods are sealing entry routes. It's a little more time consuming. So seal up your sump pits, seal up any floor drains or install the floor drains, the one-way valves, and also seal up any cracks in the floor, wall joints, control joints are a nice thing to add because that'll help decrease any cracking later on. As well as you can increase your mechanical ventilation by installing a heat recovery ventilation unit to bring in more fresh air and exhaust that old stale air. Some remediation factors to consider. So representative sample, did the individual collect the sample long enough? A 3 to 12 month test is recommended. Was the sample taken over the heating season? Was it the correct time of year? The device placement, so you're going to want to put it in the lowest level. Was the kit set up in the lowest level of the home, or was it set up on the upper levels? So these are some of the things that you need to factor in when you're going to choose to do any remediation. Also, the deployment date, was it taken within the last few years? Were there any major renos done since that? So, I mean, if someone took the radon test 10 years ago, that doesn't necessarily mean it's going to be close to the same 10 years before that when they go to sell their home. Also, was the testing done using a recognized device? So some of the continuous radon monitors can be bought off eBay or those sites for a couple $100. So is it an accurate device to use? And in the end, it's a choice of the homeowner if they want to get their home fixed if they have high radons. So it's not possible to know the levels before construction of the home because it's really going to depend on your foundation. You can have a source in there, but it's going to really depend on your foundation in the end. We've done some attached row houses where one house was fine, and then the next house right beside it attached was high with radon levels. So you don't know until you test. So in 2010, the Canadian Building Code suggested some preventative measures to be implemented, including installing plastic membrane barriers beneath the slab, sealing the basement floor, adding expansion joints, sealing around objects that penetrate the foundation to make sure that they're sealed up properly, and installing sealed sump pit tops and such. So what has RPC found? So essentially, this is a little outdated, unfortunately, this map, because we kind of ran out of room. But up in the northern parts of Canada, we had quite a bit of radon, higher radon levels above 600 becquerels per meter cubed. That doesn't necessarily, like I said before, that doesn't necessarily mean that there's going to be high radon in those levels, in those areas. So you really need to test. The highest test we conducted here at RPC was actually in the York County area. And I believe it was around the 3,800 becquerels per meter cubed. Concentration was quite surprising. So we did send out another kit, or another 2 kits, I guess, to do another double take on it. And it was in the same range. So you just don't know exactly what your radon levels are going to be like until you do the test. So Here's a couple different good programs. So the Canadian National Radon Proficiency Program, it's basically a certification program designed to establish guidelines for training professionals in the radon services industry. So they offer several different certifications, including the analytical laboratory certifications, residential measurement certifications, and mitigation certifications. And the Canadian Association of Radon Scientists and Technologists. So their goals are to provide opportunities for liaison and to promote public awareness and education. I think that's the biggest thing, is promoting, making people aware of the issues with radon, and that it can cause lung cancer, and that you should test for it and make sure that your home is safe for your family. And they also oversee the CNRPP, the Canadian National Radon Proficiency Program. And they were the ones who developed the radon real estate guidelines. So that's about everything I have, Barbara. Hopefully I didn't go through too quick or ramble too much, but I was wondering if there's any questions.
Oh, there I am. My little headshot moves around. Somebody did, what I'm trying to do is collect some of the questions, everybody. So what I'm going to say is, in the interest of time again, if you want to email those questions to me, I know there were 2 for the previous speaker, I will make sure that they get forwarded on. And for any of the speakers, if you think of something after the symposium and are reflecting on the presentations, if that's okay with everyone. I do know we also sell, you can order radon kits through the New Brunswick Lung Association website as well. And we've been doing that for a few years. And just as a personal note, again, you can't assume. I had a friend who had a brand new, well, I don't know why that's important, but a brand new cottage. And she had it tested because of course, us promoting this, and they were really high. They had to have, mitigation. So it doesn't matter if you think your home is, super new and super tight. For a small amount, about $35, I believe, you can have this test and have some peace of mind. So I thank you very much, Darren. It's very informative. Okay. All right, so here we go. I was going to mess my hair up and make it stand on end so that you can see behind the scenes what it's like when you're running one of these symposiums. Anyway, so our next topic is on the First Nations Cancer Care Plan, and Rose Neebun is our presenter. And I strong-armed her into helping me try to pronounce a few words, so bear with me. So Neebun is Wolutstikwe from the Nuguktuk First Nation. She started as the project support manager for the Moving Forward Side-by-Side Cancer Plan in 2020. Neebun graduated from Dalhousie University in 2006 with a BA in Sociology and Social Anthropology. Graduated from St. Thomas University in 2020 with her Bachelor of Social Work, and is currently working on her graduate certificate for counseling in Indigenous communities from the University of New Brunswick. Welcome, Neebun.
Thank you. Nildali was Neebun. Nilnajaya Nagukuk. I'm Neebun Bear. I'm from Tobic First Nation. And I am just gonna share my screen here. This won't take as long, short and sweet. So hopefully it gets us back on track, I guess. Oh, how does it show my notes? Nope, sorry. I thought I had this all working. Nope. I guess it won't get us back on track. Hold on.
That's okay.
How do I, okay, stop share. Try this again. So I start, as Barbara said, I started on this in 2020. The Gomolso Neebun, Dehmel, that part's Big Ma, so I'm not really good at that one. The first one is Willistigwe, so I can say that one. They both mean moving forward side by side, which is the name of the project. A little of the project background. The Gomolso Neebun, I wish I could see my notes. The Gomolso Neebun, Dehmel, moving forward side by side, cancer is an initiative to develop a plan for all New Brunswick, all First Nations in New Brunswick to improve cancer experiences and outcomes for any Indigenous person dealing with cancer. So the plan covers all the aspects of the cancer continuum, which is in the next slide, which I'll explain a little bit later. And it also addresses the cultural safety and aspects needed for a sound system of care, such as data access, service integration between various jurisdictions responsible for First Nations healthcare, and to develop relationships and a New Brunswick First Nation cancer plan with all the key partners, which are the 16 First Nations communities, tribal councils, regional health authorities, so Horizon and Vitality, nonprofit cancer organizations such as the Lung Association, New Brunswick Breast and Women's Health, Canadian Cancer Society, etc. The New Brunswick Health Council, so we help get like data and stuff from the New Brunswick Health Council, New Brunswick Cancer Network, New Brunswick Department of Health, the federal government, all are key partners on this very important plan. So like I said, that the cancer plan focuses on the whole cancer continuum. So prevention, screening, diagnosis, treatment, discharge planning, survivorship, and palliative, and all having that focus on cultural safety in all of those services. So a little bit of background on background information of the Indigenous people in New Brunswick. So there are 16 First Nations communities, and they all comprise of the 3 nations in New Brunswick, which is Mi'kmaq, Wolastoqey, and Passamaquoddy. So as you can tell from this map, I don't know if you can really see, but mainly the western or eastern side of the province is Mi'kmaq, and the western side is Wolastoqey, and down here in the St. Andrews area, that's the Passamaquoddy. It's not quite yet been established, but I think they're working on it. So a little bit of background information on the First Nation healthcare system, which I'm sure you guys are pretty aware of, but healthcare for First Nations people is provided through the provincial government and regional health authorities, and equitable access and navigation of healthcare services for First Nations, and having that cultural safety in the healthcare systems. So this is a little rates on cancer for First Nations in New Brunswick. I got this from the Canadian Cancer Society. So what it's saying is that the most prevalent cancers for First Nations in New Brunswick are lung and colorectal. So if you could tell by this slide that lung and the colorectal, there's more in First Nations than, I mean, no, they're not more, but I mean, it's pretty high considering the percentage of First Nations and the general population. So the cancer plan started in 2020. In that first year, we did the environmental scan where we went out and interviewed cancer survivors, health practitioners, First Nation health centers, the regional health authorities, pretty much all our key partners. And we asked questions and what was out there, what was missing, what they felt was missing and stuff. And also there was a literature review conducted where they looked at best practices and integrated services from across Canada to see what was also available. And in the second year from that information of the environmental scan and the literature review, we developed the plan. And from after development of the plan, we started building partnerships with all those key partners that I listed earlier. And then we came up with 9 strategic priorities in that plan. So then this third year that we're working on now, we're developing the logic model and evaluation framework for that plan and making sure that we lay out the foundation for implementation of those 9 strategic priorities and developing partnership agreements with all of the key partners and stakeholders of the plan. So these are the list of our priorities. Priority 1 is survivor support through the cancer journey, which is very important. Priority 2 is prevention. 3 is screening, then diagnosis, discharge planning, survivorship, palliative care, integrated care, and data sharing. So those are all, they're all parts of the plan. Like I said, it goes across the whole cancer continuum, but a lot of the implementation is around like prevention and screening and how we can support First Nations in those areas. Oh, I'm gonna see if I could bring up my notes here because this one's a big one that I need the notes for. How do I do that? When I was talking to the guy last time, it said it would come up. Oh. I know, I'll just share it this way. So on this slide, it talks about, how come I can't, oh, there we go. First Nations here have identified the 3 priorities, which is 1, culturally relevant information for First Nations people. So having those cultural pamphlets and booklets or handouts for all First Nation centers, New Brunswick Aboriginal Peoples Council, survivors, caregivers, Cancer Society, the Lung Association, New Brunswick Breast and Women's Cancer Partnership, the New Brunswick Cancer Network, and Horizon Vitalite. So having that culturally relevant information available in those areas. Also, the other priorities around discharge planning. So working with Horizon Vitalite, the health centers, New Brunswick Aboriginal Peoples Council, NIHB, and Extramural on creating a discharge planning plan. I know there's one right now in Horizon, that a pilot project that they're working on, but that's one of the priorities that was listed. Also, priority 3 is a culturally safe cancer care in collaboration with the RHAs, which would involve screening, diagnosis, treatment in the hospital, palliative care that the regional health authorities are responsible for. Some areas with interested partners or key elements that could be leveraged or put into place. So smoke and cessation, this is an area we have discussed with the Canadian Cancer Society and the Lung Association and the Department of Health. So looking at that smoke and cessation more closely and working on preventative measures around that. HPV immunization awareness. Increased screening rates, data sharing and integration, palliative care, radon related work, which is ongoing in pretty much every community First Nation community in New Brunswick. And that's that one. So that is pretty much our priorities of the plan. And that's my slide. There's my contact information if you want to get in touch with me, and if there's any questions or comments. If I think we have time for it because mine was very short. And Waliwin, Walawin, thank you.
I think, so we're having a little bit of an issue. Oh, goodness. So as you can tell, we are almost literally one speaker behind, and we don't really want to keep people until after 12. So what we're going to do is we're going to actually, we have a recorded presentation on the IPF, which will be up on our website. And so I think what we're going to do is move forward to our next speaker who has agreed. And she's going to be speaking on obstructive sleep apnea. So we'll start right there. And then I'm going to introduce her. Sorry. So Erica Dehmel has been a registered respiratory therapist in Nova Scotia for almost 16 years. And the past 14 years has been part of the Snore Shop team, treating those with sleep disordered breathing. Her main priority has been to help people recognize, understand, and treat their sleep disordered breathing, and help them discover the improvements in their quality of life once their sleep health is optimized. In her current role with the Snore Shop, Erica's job is to educate physicians, healthcare professionals, and the general public about the importance of testing, treating sleep apnea, and other forms of sleep disordered breathing. So welcome, Erica.
Thank you so much for having me. So I'm going to share my screen here. So as Barb mentioned, I'm going to talk a little bit today about obstructive sleep apnea. So we'll get into just the testing, treating, and how it can impact overall health. So the objectives, what I'll try to achieve today is to give you all an understanding of what snoring and sleep apnea are. We'll talk about some of the signs and symptoms to look for in yourself and your family members, and obviously any patients that you may see, and how that whole process would work if you were to get them tested, diagnosed, what they can expect with treatment, and kind of what we do long-term as far as management of somebody who has sleep apnea. So to start back at the beginning, all of this occurs during sleep. So why do we sleep? It's a really important part of our overall health, but it's an often overlooked part, something that a lot of us kind of burn the candle at both ends. But sleep's where our body is supposed to get the opportunity to rest and restore itself. So our body gets a chance to rest, but keep in mind too, during sleep, that's when the brain gets an opportunity to rest. So when you're, in a nice deep sleep, your brain's getting the opportunity to sort and file through information. So when you're dreaming, for example, that's your brain processing information, trying to make sure that it understands everything that happened, sorts it into the right part in your brain so it can be retrieved easily. Now, if your sleep is lacking, so if you're not getting the right quantity or the right quality of sleep, it's going to impact your cognitive functions because your brain's not going to get that chance to kind of defrag. So it'll impact things like your mood. Obviously, your mental health can be impacted by poor sleep. And then your physical health, your body's not getting a chance to, restore itself. So that's going to impact, your cardiac system, the blood getting to your brain gets impacted, and just all of the systems internally just get a little messed up if you're not sleeping. Like I mentioned, quantity is just as important as the quality of sleep. 7 to 9 hours is what the recommendation is. I'm guilty myself of not getting enough sleep, but as far as what adults need, that's what we should aim for, 7 to 9 hours. So when we're sleeping, why do we snore? So where does snoring even come from? So generally, snoring stems from having a small airway. So when you're asleep, your muscles relax. The muscles in the throat are no exception. They're going to relax too. So when you drift off and you've got a small throat, those muscles start to vibrate, and that's where that noise of snoring comes from. Now, for some people, they only snore occasionally. So things that relax you can cause snoring to get worse. So things like having a few drinks, if you've gained a little bit of weight, there's some things like, you know, pain medication. Sometimes, you know, if you're recovering from surgery, you'll take like a muscle relaxant. Obviously, that's going to make your airway narrower. But even things like allergies and a head cold, your nose is part of your airway, so that gets stuffed up. So it makes it harder to breathe through your nose, and that can increase snoring as well. Now, the snoring itself is not necessarily a health problem. It's maybe an annoying problem for the person that has to listen to it, but really the snoring itself is okay. The problem is what the snoring indicates. And if somebody's snoring, it means that their airway is restricting. And often that can lead to the restriction turning into an obstruction, which leads me to obstructive sleep apnea. So with obstructive sleep apnea, OSA, it's just the airway is relaxing to the point that it's actually closing. So what ends up happening is, you know, the body relaxes, muscles relax, throat gets a little narrow, the snoring starts, and then it progresses to the point that the throat closes. When your throat closes, obviously you're not breathing, so your oxygen level drops, which sets your body into a little bit of panic, understandably. And when your body panics, it increases your heart rate. Your body sends out a lot of stress hormones and chemicals. And then it also tries to figure out what's causing this fight or flight and what can I do to reverse it. And usually what reverses it is waking up. So the body brings you out of sleep just long enough so that your muscle tone comes back, you catch your breath, and then you go right back into it. So in someone with a narrow airway and their muscles relax, they can stop breathing for more than 10 seconds. And that happens repeatedly. So it's the repetition part that's a problem. If you were to just stop breathing once through the night, not a big deal. But it's when it keeps happening over and over and over again, it becomes a little bit of a vicious cycle. Now, it seems like sleep apnea is pretty prevalent, but just to kind of put it into perspective, it's estimated that as many as 6 million Canadians suffer from sleep apnea, but we've only diagnosed like 20% of them. So there's still a huge population out there that we haven't found yet. And it's something that's getting a lot easier to screen and test for. So some of the symptoms of sleep apnea, snoring, of course, but restlessness, complaints all the time for people with sleep apnea that they just can't stay asleep. They just feel like they wake up a lot. Clearly, if you're choking or gasping in your sleep frequently, you're probably going to ask about that. If you're up a lot through the night to the bathroom, that's a sign of sleep apnea too. Excessive sweating kind of comes from that stress response. Morning headaches, so just waking up with a headache is not a good way to start the day. And sore throat and dry mouth just from the snoring alone. Daytime tiredness is going to come from that disruption in the sleep cycle. And then, like I mentioned earlier, some of those mental faculties, so difficulty with memory, focus, concentration, and then progressively worsening, you know, irritability is common. But if it's kind of a chronic problem, it can lead to depression and anxiety long-term. So a screening tool that we use in the industry is something called the Stop Bang. And basically what it is 8 simple questions you can ask to see if someone may be at risk of having sleep apnea. So the stop part of it, S-T-O-P, the S stands for snore. So does the person snore? T, do they feel tired through the day? O, has anyone observed that they've stopped breathing? A lot of people stop breathing in their sleep and have no idea it's happening. It's just the bed partner that notices it. And the P in stop is for pressure. meaning your blood pressure. So do you have blood pressure, or are you being treated for high blood pressure? Hear it all the time. People say, I don't have high blood pressure. I'm on medication for it. So you do have high blood pressure, it's just being treated. That's a risk factor for sleep apnea. BANG, B-A-N-G, is BMI. So BMI over 35, higher risk of sleep apnea. A is for age. So anyone over 50. Neck, the size of the neck, bigger the neck, the more it compresses the airway. So it makes you more at risk of developing sleep apnea just because there's not going to be enough room in there. And G is gender. So it is more common in men. So with those 8 questions, if you answer yes to 3 or more, it puts you at a high risk of OSA. So if there's ever a time where yourself, family member, or even one of your patients kind of fits that bill, always worth screening and figuring out, do they have sleep apnea? So how do we diagnose it? We do an overnight sleep study. And there's a couple of different ways that a sleep study can be completed. You know, in a perfect world, everybody would have something called a polysomnography or a PSG, which is an attended study that's completed in a lab. So in Atlantic Canada, that's typically done through the hospitals. So it would be, you know, a lab where you'd go overnight, you would sleep in the hospital, you'd be wired head to toe. So lots of things measured during a polysomnography. But for most people, the easiest thing is to do a study in the comfort of their own home with just a few things being monitored. So with the polysomnography, that lab study, you need a referral from a physician or nurse practitioner. You've got to, again, get booked in to stay overnight. A technologist would monitor you throughout the night and kind of, you know, check things out as it's going. So it's a little bit more labor intensive, requires, you know, really specialized training. So the wait times are really long. I know in pretty much mostly through the Atlantic provinces, the wait time can be upwards of 2 years for a lot of people, which is a long time to be waiting just to find out if you're stopping breathing in your sleep. You kind of want to fast track that. So that's where home sleep tests have come into play, and technology's advanced a lot. So with a home sleep test, it's basically just taking equipment home, wearing it overnight, returning it the next day for the data to be retrieved, and you can get a diagnosis like within a week or 2. So visually, just so you kind of see the difference, on the left is what you'd be wired up to with an in-lab study. Then on the right would be an example of a test that you could do to screen for sleep apnea. So with that in-lab test, sometimes it is necessary for more complex sleep issues, but for just, you know, your straight run-of-the-mill sleep apnea, we're just trying to figure out if you stop breathing, just that thing on the right's all you need. So what are you going to see on a home sleep study? The main number we're looking at is something called an AHI, and that stands for Apnea Hypopnea Index. And all that is the number of times an hour that you stop breathing for at least 10 seconds. Now, with that, we're monitoring a few different channels. First of all, we're looking at the oxygen saturation in the blood, the heart rate through the night. But another thing that a lot of these devices measure is your body position. So if you're on your back, your side, your stomach, you can kind of measure if you're tossing or turning, how loud your snoring is, which maybe, you know, medically isn't important, but people are always very curious to know how loud their snoring is. Kind of justification for the person that's sleeping next to them too. And also sleep stages. So are you getting a good quality sleep? Are you hitting those deeper stages of sleep? Those are kind of the big ones, the big things that we're looking for on these tests. So when we are diagnosing sleep apnea, there are different degrees of severity. And the severity of sleep apnea depends on how many times per hour you're stopping breathing. So somebody who stops breathing less than 5 times an hour is considered to be normal. Anything from 5 to 15 times an hour is considered to be like a mild case of sleep apnea. Moderate sleep apnea is if you stop breathing between 15 and 30 times an hour, and anything over 30 times an hour is considered severe. So obviously, the more frequently you're stopping breathing, the more impact that's going to have on your physical and mental health. So it's associated with more risk the more severe your sleep apnea is. Any stage of sleep apnea is worth treating, but with severe, you're just putting yourself at a higher risk of having some negative consequences from a health standpoint. So regardless of severity, if left untreated, there's been tons of research about the impact that can have on patients. So more likely to develop cancer. And a lot of that has to do with kind of the oxidative stress that comes from that drop in the oxygen, that resurge. It's really hard on the cells. So it increases the likelihood of cancer. It makes you 4 times more likely to have a stroke. So a lot of protective mechanisms that our body put in place when they're put under stress puts a little bit of excess strain on that cerebrovascular system. So it does make them way more likely to have a stroke. Also a higher mortality rate for long list of reasons, but basically if the body's not resting and it's not restoring, it's just really hard on all of the systems. From an occupational health standpoint, traffic accidents, 15 times more likely to be in an accident if left untreated. So that's why a lot of people in the transportation industry, sleep apnea tends to be something that's looked at quite a bit. Reaction times really drop off, and obviously, tiredness at rest. Those are big risk factors if you're driving for a living. And then looking at comorbidities, 83% of patients with high blood pressure also have sleep apnea. So there's a huge correlation there with the diabetic population too. 48% of patients with diabetes also have sleep apnea. The factor that really plays into this is that fight or flight that comes in when you stop breathing. So that fight part of it means your body thinks it needs energy. Energy is in the form of sugar. So somebody with recurrent apneas through the night is going to release sugar into their blood. So tends to be really high fasting sugars in the morning. So if those fasting sugars are a real challenge to control, definitely screening for sleep apnea makes sense. And I mentioned mental health being a big part of it too. So 40% of patients with depression also have sleep apnea. So some of the treatment options when we're talking about sleep apnea, most people have heard of CPAP. That's kind of the gold standard of treatment. Now, I mentioned more severe cases, more health consequences. Good news and bad news, I guess, if you have a diagnosis of mild, so, maybe not as many immediate problems from a health perspective. But it also means that, you can experiment a little bit with some treatment options. For some people, it's just as simple as weight loss. So, excess weight, when we are overweight, we carry it everywhere, and your airway is no exception. So sometimes weight loss corrects it. For some people, it's a little bit easier for them to get their head around using something like a mandibular advancement device, which is almost like a dental appliance that would have to be fitted, obviously, by a dental specialist, but it would position the jaw forward, which pulls all the tissues in the front of the throat forward to create a bigger opening so that the apneas are less likely to occur. I mentioned a lot of the tests measure head position. So for some people, they only have sleep apnea when they're on their back. Gravity's not your friend when you have sleep apnea. You lay on your back, everything falls back. So for some people, it's just a matter of positioning themselves so they stay on their side. That can be something as simple as like a wedge pillow. There are, bumper belts that you can get that you wear around your chest, and it prevents you from going onto your back. So there are some options there. And in some cases, it's a matter of seeing an ear, nose, and throat physician, so a referral to an ENT, to see where your restriction is and if it can be corrected surgically. So sometimes just removing excess tissue, the back palate, your tonsils, adenoids, those sorts of things kind of reduce the space that's inside your airway. And so sometimes that can be an option, obviously not a quick option, but it is something that can be done. For most people though, CPAP tends to be the route that they end up going. So what is CPAP? Well, CPAP stands for continuous positive airway pressure. So in a nutshell, all it is a device that gives you a constant flow of air. And what that air is doing, it's pretty much inflating the throat from the inside out. So it holds the airway open so that obstructions don't occur. There's a couple of different ways that you can receive CPAP. It can be delivered in an automatic function. So in those cases, the machine itself will kind of start off at a low airflow and then it kind of monitors the breathing pattern. And when it senses that there's a restriction in the airway, it automatically gives a little bit more air to kind of inflate it and then backs off when you don't need it. So a lot of people prefer the automatic adjusting. Doesn't work for everyone though. And in those cases, sometimes we need to titrate a device so that it stays at one specific level throughout the night. So in those cases, the machine would just deliver one pressure. So it's not, fluctuating all through the night, and just enough to maintain the airway. Now, when you get diagnosed with sleep apnea and you're faced with, treatment, I know I hear it all the time from people. I don't want to wear a big thing on my face. I can't imagine being hooked up to a Darth Vader machine. I've heard it all. Again, technology has advanced for sure. CPAP devices are very small. They're very quiet. I can assure you of that. The snoring is a million times worse than the treatment. And there's tons of mask options. It doesn't have to be a big bulky thing on your face. The masks that I have across the top are probably the more popular ones. Some of them are something as simple as little prongs in your nostrils. A lot of people worry about getting tangled up in the tube if they're moving around a lot in their sleep. So there are ones that you can kind of tuck up and out of the way. And just visually, you can see size-wise, the machines are not big considering what they do. They're pretty impressive. They've come a long way. And as far as monitoring, obviously you need a healthcare professional to kind of guide you through the whole process, make sure that you're getting the proper treatment, but you can self-monitor too. So really, in a nutshell, the CPAP devices are just trying to keep the airway open, and that apnea hypopnea index that we talked about when we were talking about diagnosis, that's something that we can measure while you're using the CPAP, so we can make sure that it is actually working. Another factor that's really important is making sure you have a mask that's sealed. All of this hinges on the mask having an airtight seal. So there are indications on the device itself to tell you if your mask is fitted properly, and then making sure you're using it. Just having the CPAP by the bedside does you no good. Unfortunately, you do have to actually turn it on and use it in order to get any benefits. So, tracking usage. Most machines now do have like wireless data transmission, and there are apps that link into it. So there's some coaching through the apps. It'll give you little notifications to let you know if your numbers are looking out of whack. At the end of it, the benefits, once you get on track, the benefits are what keep people going back to it. So by taking care of the sleep apnea, the snoring goes away. So that's one big thing. Much more restful sleep improves your health conditions, right? Like especially your cardiac health, keeping your heart healthy. And, obviously increased energy and feeling a lot better. Like there's a lot to be said about that. If you are somebody who experiences headaches, waking up without a headache is amazing. And if you're getting the proper REM sleep, that deep stages of sleep through the night, it helps improve memory, focus, and concentration. So you feel clearer. Because you have, better mental capacity, there's a reduced risk of, poor reaction times you're falling asleep at the wheel, so reduced risk of traffic accident. And then obviously, if you are somebody with type 2 diabetes, it reduces the sugars that are being released unnecessarily at night. So it can help your diabetes, but also put you at a lower risk of developing it. And it can also improve your immune system. When your body's resting, it's stronger. So an important aspect of sleep apnea is making sure that you have a group that's helping support you. So my entire career has been with the Snore Shop, and we talk about a patient journey. So the first step in that journey is, linking the symptoms of sleep apnea and determining if you or this patient may have it. So that discovery phase is kind of like that thinking about it phase. And then if you've kind of decided, no, you know what, I think this person does have sleep apnea, next step, let's confirm that. So get tested for sleep apnea. In the Atlantic region, a referral from a physician is not required to get tested. So anybody can refer anybody for a test, and you can self-refer. So you can book your own appointment to at least get diagnosed. Once diagnosed, depending on what the results show, then everything gets tailored to the individual's needs. One size does not fit all when we're talking about snoring and sleep apnea. So depending on the severity of your condition, trying to figure out what treatment's going to work for you. CPAP may not be practical for somebody who's traveling constantly or, lives in a spot with really spotty power. It may be that they're not a candidate for any other alternatives. They're really got to make the CPAP work, deal with, concerns about being claustrophobic and uncomfortable, all of that. There are things that we can do to tailor it to each individual. So getting that personalized therapy is important. You need somebody to help you navigate that. And then it's not just the getting set up with CPAP that's important, it's that long-term support. So even, somebody who takes right to using CPAP, they need that encouragement long-term, and situations come up where you might need support. So experiencing the benefits is that long-term support. So for most people, if they are diagnosed with sleep apnea and they decide to go through with CPAP therapy, it tends to be a 1-month titration, figure out what works, what doesn't work. At the end of the month, if they decide to continue on with the treatment, then we usually follow up every 6 to 12 months, depending on the individual. And so, having somebody that's always there to kind of help you out through all of this, encourage you. Actually, a lot of what Melissa talked about earlier really resonated with me, because we do a lot of the same things. A lot of that coaching is really important to make sure people are experiencing these benefits. So anybody had wanted to look into some more details about sleep apnea, if they're looking for more information, if you want to book a test for yourself or somebody else, by all means, our website, really easy to navigate, so you can find all that information there. And I am always welcoming anybody to ask me any questions. So erica@thesnoreshop.ca, if you had wanted to pop me an email. And I believe Barb was also going to maybe retrieve some questions. And to answer Shannon's question that I see in the Q&A, testing is free. So no financial barriers.
So we'll if another question comes up, we'll certainly ask it. So what we've done, as I said, we've had almost like a runaway train session, and my apologies, but what I'm going to do, so please don't drop off the symposium yet. We're going to have a very important survey that I ask you to do each year, because it helps us determine what topics of interest to pick for next year's symposium. So I'm going to do a quick little recap of a few things that we had to race by. I want to mention, please take the opportunity to view Dr. Poirier's recorded presentation that'll be on our website. And in his presentation, he's going to be discussing idiopathic pulmonary fibrosis, but also the umbrella term, which I wasn't familiar with that well, called PF-ILD, which is pulmonary fibrosing interstitial lung disease. So that actually covers a number of other lung diseases as well. He also discusses the treatment for these lung diseases. The two medications are meant to slow the disease down. They're not a cure. And so Esbriet is indicated for IPF and is also covered under the New Brunswick drug plan. OFEV is covered for all three indications, idiopathic pulmonary fibrosis, the PF-ILD, and scleroderma ILD. So take the time to watch his video. I want to then make a few closing remarks. NBCC students, do not email me for your certificate. Your instructor will have a copy of the certificate. It's a generic NBCC attendance certificate. And so you will go to her and answer no, I'm just kidding. I was going to say, answer the questions about what you watched in order to get it. Anyway, you talk to your instructor about your certificate. Then thank you for the healthcare practitioners that are already been sending me emails and designating your profession for the type of certificate you need. I also want to mention, it's not up and running, but we are hoping to launch a sleep apnea CPAP program for New Brunswickers, in which we will hopefully get secondhand machines and be able to turn around and give them back to New Brunswickers who cannot afford a machine. Again, our lung transplant support program, if you're interested in knowing more about that, please send me an email and I'll happily send you information about it, and if you want to call and talk. So I want to once again thank our sponsors, Boehringer Ingelheim Canada Limited, Merck Canada, Pfizer Canada, Sanofi Pasteur, and Vital Air for sponsoring this educational session. As I mentioned, please do that survey. I rely on it a lot for next year's symposium. I think that is it for now. So we're actually going to end up finishing a little early. I think Dusty, oh my goodness, I meant to thank Dusty. Dusty Green is our manager of marketing and communications, and he's my sidekick through this whole year-long process, and then runs things behind the scenes. So a big thank you to Dusty. I believe he's going to do something about the survey. I'm not sure if I can actually see it. Someone asked, when will Dr. Poirier's presentation be posted? Well, I'm not sure if it's today. As you know, tomorrow is our recognition of Truth and Reconciliation, so nobody will be in the office. But I know Dusty will get on it and try and get that up. And we have permission for pretty well all the PowerPoints to be uploaded as well. So just check back on our website, and things will get posted in due time.